Recording in progress.
Unmute. So can you hear me? Did you hear me?
Yes, we can hear you. Okay.
Thank you.
Yes, we can hear you.
Thank you very much.
Good afternoon. Today is July 26, 2023, and it is 4:03 p.m. As a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Budget and Finance Committee. As a reminder, some of our committee members may be also participating via video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. The first item of business is public communication. Members of the public who wish to make comments virtually during the public communication portion of the meeting must have registered with Central Health via the online form or by telephone no later than 2:30 p.m. today. Yes, and did anyone register to make comments for the Budget and Finance Committee meeting? Anyone from the communication team?
No one registered.
No one. So we do not have any public comment. So moving along, before we begin, community members, I would like to reassure you and members and the public that Central Health and this board and committee strive for transparency regarding the annual budget and tax rate setting process. However, due to ongoing litigation, there may be certain budgetary items that we cannot discuss in open session, and we will have a closed session in our upcoming Board of Managers meeting where some of these questions may be addressed. With that, we will now proceed with our Budget and Finance Committee agenda. The first line of item is item 1, approve the minutes of the June 14th and July 12, 2023 Budget and Finance Committee meetings. I have a motion.
I move to
Dr.
approve
Bell.
the minutes of the June 14th and July 12th, 2023 Budget and Finance Committee meetings.
Thank you. Do I have a second?
I second.
Thank you, Manager Brinson. So I have a first by Dr. Bell and a second by Dr. Brinson. Any further discussions? So I see none. All in favor?
Aye.
Aye. So this motion moves unanimously. Second item, receive and discuss a presentation of the fiscal year 2024 preliminary budget and financial forecast for subsequent fiscal years, including information on possible property tax rates to be assessed. For this item, Mike Giesland, Jeff Knodel, and Kim Johnson will be presenting. Members, this is our second kickoff for our budget season, so I understand there's going to be a lot of, you may have a lot of questions, especially for our new board members. I would want to allow our presenters to present, and then we'll take on any questions that you may have. And also understand this will not be the only meeting we will hold for this. We will have subsequent conversations, and we have no action item. So this is really a preliminary, opening up our tax rate. And as nothing is set in stone, and we are, and I also appreciate everyone who submitted their questions. I believe Jeff may be able to answer some of them today, and the rest you will follow up with those questions. Is that correct? Thank you. So the floor is for you. Mr. Giesland, are you going to start?
Yes, thank you, Chairman Sida.
Thank you.
Members, I'm going to provide some context to what you're about to receive a presentation on. And as the chair mentioned, this is a starting point for us. And so we always talk about the strategic building blocks that drive funding recommendations. But then we also come to you with this long-term financial forecast that you see before you today. And it really addresses reserves and the inflows and the outflows so that you can see in a multi-year period, excuse me, what is what we are forecasting, and it helps you make better decisions by taking the long view. I do want to address a few things about reserves. And again, to put some context around this, these reserves are not a war chest to seize property, period. They are not that. What they are is a very smart and prudent means to build out a high functioning safety net system, safety net healthcare system that provides patient care and to fill in gaps in the patient care. And it helps us manage risk, including hospital risk, changes in funding programs, et cetera, which we've all experienced in hospital districts over the years. And lastly, what this does is it allows for sustainability for the long term, so that what programs or lines of service that we do provide or gaps that we're filling, that when we make that funding commitment, we know that we can do it year in and year out, and that people will be able to rely on the patient care that we're providing. So just wanted to put some context around that. Thank you very much, and I'll hand it off to Jeff.
Thank you, Mr. Gaislan.
Thank you. Starting the presentation, and thank you for your opening comments, Chair. This is the first step in numerous steps in the budgeting process, and we always, the last several years, have kicked the process off with a financial forecast. And so there'll be plenty of opportunities to make adjustments, make changes, and have discussions. So this first step, the financial forecasting, if we could advance the slide. Just what is a financial forecast? It's an initial financial tool in the budget process that aids the board to assess and evaluate current and future fiscal conditions. Just so everyone knows, these are estimates, estimated amounts. Again, just kind of my spill on it is they're estimates, and I'll assure you they're not the exact numbers, but they help us evaluate trends, future trends, to help us develop policies, objectives, future strategies for revenues and services. And then lastly, the purpose of a financial forecast allows organizations to take a longer view to prevent volatility or disruptions in funding sources or services. So what does that mean? It simply means it helps alleviate organizationally known or unknown risk that we may have organizationally, that we want to prudently evaluate our future financial state in order to provide the services that the board deems necessary for the community. Next slide. So we're cutting right through about at least 10 slides here and just presenting our 7-year financial forecast, and we'll have a lot of detail to talk through. We put this slide up just to kind of cut to the chase of as far as our financial reserves and sources and uses, where staff has landed as far as making a recommendation to prepare the upcoming fiscal year 24 proposed, and I emphasize proposed budget. Again, many opportunities for input and changes. Just quickly, I want to point to where staff has landed. One of the big reasons we do a financial forecast is we want to look at what we expect to spend over a period of time and look at our year-over-year tax rate. one of the emphasis that we want to portray and evaluate in a forecast is a steady year-over-year tax source. Volatility is not good. And so that's how we look at it over this period of time. There are going to be a couple of other slides that we'll go through, but I do want to point out that our format is just a tad different this year, and we'll point that out. I also want to point out that under our uses or our spend, that there are two components or pieces of that, and you see that in the chart, the table below. Sources would be revenues that we would expect on an annual basis, and that's an aggregate of both property taxes and other revenues. And then there are two lines for uses, health equity action plan, new uses. Those amounts are incorporated into the financial forecast. I think you had a presentation in our last meeting regarding some of those projects and initiatives, and I think there's another meeting scheduled next week specifically related around that. But the intent of the format is to show not only the ongoing costs, which you see in the next row, titled Ongoing Healthcare Delivery and Operation Uses, but also that we're incrementally adding the healthcare equity action plan cost on an annual year-to-year basis in the forecast period. So I just want to point that out, just so you're aware that we've incorporated what was presented at the last meeting. So with that, I'm going to turn it over to Kim to walk through several slides.
Next slide, please. So this year's forecast, as you've seen, covers the next 7 years. And as Jeff mentioned, we have tried to incorporate a lot of assumptions so that we can help mitigate the risks and kind of stem some of the possible volatility over the future. And so we also have evaluated our reserve levels and how the future uses and future sources will impact those reserves as we try to meet the needs of the system of care implementation. And this, as Jeff just showed, will guide our recommended tax rate for the next fiscal year. Next slide, please. Some of the risks that we're accounting for in our forecast include the potential of economic recession, downturn or recession, as well as ongoing inflation. There's also the potential of some regulatory impacts with possible unfunded mandates or funded caps from the legislature, as well as the status of the LPPF and the 340B pharmacy program subsidies. And then there's also financial risks that we have related to if we need supplemental funding for a value of services shortfall or risk-based capital requirements, as well as the FQHC PPS payment levels. Next slide. So some of our revenue-related assumptions include in future years a lower new construction rate than in the current year, which is about 5.7 billion. Also, we assumed that the taxable values are going to grow at a slower rate than they did in the current year for future years out to help project a steady tax revenue base that will stem some of the volatility. We anticipate our other revenue sources will continue fairly steadily, except the CEC lease is going to be discontinued after 2024. And we assume no additional downtown campus lease payments with minimal third-party revenue assumed in the forecast. Next slide.
Can I jump in real quick and just make a comment? I just want to make a comment on the first bullet point. $5.7 billion sounds like a big number. That is the taxable value that's new taxable value year over year. It is a big number, but our total taxable value in Travis County is, I think it's around $250 billion, something in that regard. So I just didn't want anyone to be misled when you see $1 billion. That's from a percentage wise fairly small, and when you really look at taxable value, our tax rate is per $100. So just, doing quick round math, $5.7 billion would be about $5 million that we're adding, $5.7 million at a 10-cent tax rate, which we're really close to. So I just wanted to point that out, that it may seem like a big number. That's fairly standard year over year when new construction comes online in Travis County. I just didn't want there to be any confusion that there's some new huge revenue source or tax inflow. This is just a normal number, and when you see billion, that usually raises eyebrows. So thank you for your indulgence on that.
So as far as uses go, obviously with the implementation of the Healthcare Equity Action Plan over the next 7 years, we do anticipate some significant increases in uses of funds. We have new facilities that are coming online in 2024. We anticipate Del Valle, Hornsby Bend, and Rosewood, Zaragoza. And then in future years, completion of our medical respite care sites at Hancock, Colony Park, and the Cameron Center. And then, increases in purchased services for primary care and specialty care, as well as the transition of the CCC full cost over to Central Health beginning in FY24. Next slide, please. So some of our assumptions in estimating the future healthcare services are an increase of about 3 to 8% for medical inflation. Jeff also pointed out the Healthcare Equity Plan implementation we have accounted for fully in our forecasts as well. And then we have just estimated various increases for salaries to maintain a competitive pay rate within the labor market and to support implementation of direct specialty care services and facilities.
Okay, next slide. So we're about to go through a few charts. So I just wanted to pause for a second. These are our reserve charts. What is it that we're trying to look at? What are the objectives of the financial forecast charts? We first of all, we want to ensure that sufficient reserves are maintained over this time period, and quite frankly, subsequent to the time period, because you really don't want to end up at the end of a period right on some dotted line and the trend isn't promising for the next year. the reserve levels are sufficient to maintain the service levels that you're outlining, that you objectively are trying to achieve for the services that we provide to the community. And then last, but certainly not least, is that there are some tolerable gaps, the structural gaps. So you'll see in the upcoming slides, you will see for a number of years, if not all years, really all years, our spend is greater than our sources, or our spend is greater than our revenues. And that's one of the reasons why over the past number of years we've been building our reserves up in order to implement a healthcare plan that addresses the gaps that we have in our community. And so you'll see that that starts and it widens out, depending on what the tax rate is, will widen out at some point. But what we look for is at the end of the period that there's a tolerable gap. In other words, a trend that's closing the gap over the period. Next slide. So this is one of three slides that look identical. When you just look at the picture, they're identical. And in the upcoming three slides, the only variable you'll see is a different year-over-year ad valorem rate. So we're going to show 6, 6.5, and 7%. So just kind of spending a little time looking at this chart, there are, to some degree, three elements of information, the uses and sources. So again, this is the spend, revenues, and expenses, whatever you want to call it. And then you see the shaded area with negative numbers. This is the gap that we're talking about. And so if it was the other way around, if our sources were greater than our uses, you would see a positive amount. You would see positive numbers. And so you see the trend on this particular graph is there obviously is a structural gap, and it's narrow beginning in 2024, and it starts widening out. The maximum gap is in fiscal year 2029, and then you see it starts to close, but it's still to some degree substantial, and it's not closing at what I would consider a very fast rate. The other line that you see are just our reserve totals, and again, you see the buildup of reserves. You see the total reserves at the bottom row of the table. And then, of course, you see the decline as we have a structural gap. You see that our revenues decline over the forecast period. I want to talk a little bit about the table. Again, the sources are just our aggregated revenue sources. Our health equity action plan, what we're calling the new uses. These are incremental new costs related to the health equity action plan that's been developed. They're also aggregate cost year over year. So, for example, if you open a clinic and you're staffing a clinic, that's an incremental cost, and that's an ongoing cost that more than likely will increase year over year. And so as we look at our forecast period, we're aggregating costs as we add the projects that I think have been talked about, the cost of implementing those projects over this time period. So I just want to make sure everyone understands that there are two elements of our uses this year. We took the base budget, which is really the fiscal year 23 budget, and we've rolled that forward, and then we've also added our healthcare plan cost related to that. The other thing that I would bring up that is a little confusing. But at some point, you just have to say this is the rule that we'll try to work with. We started the new use cost in fiscal year '24, even though there may have been some cost in fiscal year 2023. And it really was just to try to come up with a rule that we could roll forward in the forecast period. So there are some costs in fiscal year '23. For example, at the very tail end of 2023, there were some limited costs related around Rosewood, Zaragoza, and bringing on some staff related to that. So it's probably the cutoff is more fiscal year based, but there are some additional costs related to the healthcare action plan in fiscal year 2023. But overall, it's not hugely material. Next slide is again the same slide. If you really looked at all the numbers, you would see they're almost the same, except the sources are a little different, and the reserves are a little bit different. So what's the difference? The variable is we increased our year-over-year tax revenue from 6% to 6.5%. And so you see some of the same trends. There's still a structural gap, but what you do see related to the gap is it's starting to close, and it's closing at a first of all, it's not as substantial as the previous slide, but it is closing. And then of course you see our total reserves at the end of the forecast period at $268 million. And then the next slide is 7%. So again, only change is the rate increasing to 7%. You see higher reserve numbers. You see the power of compounding. If you compare the amounts, and then you see that again the gap isn't as substantial, and then you see it's closed even further. Related to this tax rate. Next slide. So how do we summarize these charts, and what is a way for us to look at what it means? I know it says days of cash on hand, but the metric is actually it's days of reserves on hand. But we use this days of reserves on hand as a financial metric to evaluate where we want to be as it relates organizationally to some of the things we talk about related around reserves, mitigating risk, being able to provide the services that we intend to provide to the community without disruption, and also where we want to land from being a financially prudent organization. And so you see the three lines that outline the three rates that we just presented, the 6, the 6.5, and the 7%. And what you really notice is the 7 and the 6.5% are above our targeted days of reserves on hand, which again, that green area is a metric that we try to maintain between 120 and 150 days of reserves on hand. You do see that the blue line, or the 6% year over year, falls within the range. I think the concern that we had, financially speaking, so to speak, is that we're in the targeted zone. But if you remember looking at the gap, the structural gap, it really wasn't closing as quickly as we would like it to be, knowing that we're in our target range at the end of the period. So we have, staff has evaluated the three and made a recommendation, and I'll get to that here in a second. I do want to just quickly read off, the board recently approved issuing debt. And part of issuing debt is you go through third-party rating agencies. And I just want to read off a couple of the comments that they had. So this is a third-party review of Central Health and its financial status. Looking at credit strengths, what they noted was healthy liquidity provides a cushion against operating risk and extremely modest debt burden. So I think, this has been, we got our rating because of the prudent action that the board has taken as far as building up the reserves so that when we're taking on substantial operational risk, we have the cushion or the reserves to help mitigate the unknowns and the risk associated with that. And then it probably wouldn't surprise you that the challenges that they saw as it relates to our rating was increased costs and startup associated with operating clinics to provide direct healthcare services. So they quickly identified Central Health, you're going into a new lines of business, potentially with some risk in it being specialty care, and we know that's a challenge, but you have some of the reserve capacity to both operationalize that and to have some cushion as far as mitigation. And then the last one of their other comments was just ongoing support for the district's insurance plan, and that's there's always risk associated with having an insurance plan, and that's certainly something that they noted as it relates to our bond rating. So next slide. So what are the takeaways related to the forecast? Reserve levels have been accumulating over the past few years, but will be required for future uses. I think at this point we know related around the implementation of the Health Equity Action Plan, and in addition, we've always had federal funding risk. There is federal funding risk related around the value of services and any shortfall related around our agreement with Ascension. You need reserve levels in order to mitigate these type of risk. Long-term property tax revenue stability will provide the necessary financial resources to implement and sustain a high-functioning system of care. So we need to have a steady source of revenue. We need to have revenue in order to prevent any disruption of services. And that's an important strategy, and that's why we look at, that's why we do a financial forecast, is we want to develop the strategy and the plan in order to have sufficient resources in order to provide the healthcare system to our community. We will continue, financial staff will continue to monitor any debt issuance opportunities for capital projects. And last but not least, and I know this is a real general comment, but we're looking at a 7-year period. We look at this every year and make adjustments accordingly. We're adding more cost, we're adding more risk, we're adding more potential volatility. We have to monitor our progress year over year and adjust accordingly. Next slide just gets to our recommendation on the staff side, which is to prepare the fiscal year 2024 proposed budget at a rate of 6.5% over the maintenance and operations no new revenue rate. Again, there are going to be ample opportunities to look at costs, to look at rates. In fact, I probably will assure you, even though we have fiscal year 24 numbers, in our forecast. They will change between now and the proposed budget, just as we get more information and have more detail. But at some point, we've cut the process off and done some estimates, and this is where we've landed as it relates to our forecast period. Just real quickly, a couple of key dates, and I mentioned that there are a number of opportunities related to our budget process. Next week, we'll have a presentation related around our Health Equity Action Plan. And then the 9th will be the presentation of the Central Health proposed budget. So this will be the actual fiscal year 2024 budget. So we will start focusing on the upcoming fiscal year and not as much on the 7-year forecast period. And then we have some community conversations scheduled in mid-August, and then we'll come back on the 23rd for a Central Health Board of Managers meeting. And then we'll have a public hearing that next week at the end of August, another meeting on the 6th, and then we start going to the Commissioners Court. So we have a work session scheduled for September 7th with final consideration from the Travis County Commissioners Court at September 26th. So Chair, that concludes our presentation. Thank you for the time
Thank
to
you.
present our forecast, and we'll be happy to answer any questions.
Thank you very much, appreciated. As we stated earlier on this meeting, this is just the start of our budget. We are not, we're not going to be voting on anything, but it will be good to hear some of your insights and some direction if you want to give staff. That will be helpful. But I also want us to be a little mindful of the time as well. I know there's a lot that we want to discuss, but I am gonna open the floor to some questions. I just want to keep you all, please just be mindful of the time that we have. We have a very long night as well. So I'm gonna start with Dr. Martin. Do you have any questions?
And this just speaks to my ignorance on this issue. When you talk about 6.5 versus 7% over no net revenue, could you explain fully what that means?
Yeah, so in property tax lingo, there are two components of the property tax rate. Let me start with debt service. So debt service is one piece of it.
Mm-hmm.
Whatever your debt service is on an annual basis, the rate is whatever supports that debt service. So that's just, think of that just as a kind of a fixed calculation. The variable in the tax rate is what's called M&O, the maintenance and operation. So think of this as the operational piece of the tax rate. And so it's measured think of it not from a rate perspective, but think of it as it's a revenue number in a base year, and a 6% increase would mean the total revenue in the subsequent year, the next year, increased by 6%.
Gotcha.
So for example, if your revenue is $100 in year one, and it's a 6% increase in year two, your revenue would be $106. So 6%.
And that's what we'd be requesting of the county commissioners.
Yes, we go to the Commissioners Court. Well, so this is the start of the budget process. I don't know what we're asking them to consider and approve. We go through a number of meetings with the Central Health Board. Ultimately, we come up with our final budget that you guys vote on, and it goes to the court for consideration.
Okay, thank you. I have one last question. How are the reserves invested? We have $450 million in cash.
Yeah, so they're invested in mainly tax pool type investments that are really, think of them as governmental treasury notes. I think that's primarily what it is. We adhere to the Texas Public Funds Investment Act, and originally was called the Prudent Investor Rule, which doesn't allow us to invest in risky or volatile type of investments, so they're really government-backed investments.
Like federal securities and things like that.
Yeah, there's a lot of, I think Fannie Mae, I saw that Fannie Mae and potentially Ginnie Mae, Fannie Mae, yeah.
Okay.
So
Thank you.
mortgage-backed, government-backed securities.
Thank you.
Thank you. Manager Kitchen?
I have two quick questions, two short questions. The first one is process. So if I'm understanding correctly, on August 9th, that's when you all will present the proposed budget, and y'all going to use the 6.5%. Okay, and that's when it becomes public, is that right? Is it that point, August 9th?
That's one proposed budget.
Yeah, proposed budget, that's what I'm talking about. Okay. And then the second question is, I'm curious about the taxpayer impact. Will y'all be presenting the taxpayer impact on August 9th? So that's when you'll,
Yeah, we just received the certified roll a couple days ago.
okay,
So that will be part of the presentation. Yeah, so you were asking about taxpayer impact. Yes, we received the certified tax roll from the postal district a few days ago. So we will calculate the taxpayer impact and probably present the kind of the usual amount of data that we have. Certainly, if there are any additional questions, we can answer those.
there are some bodies, what I'm familiar with is the taxpayer impact statement that some bodies, like city does, for example, presents, that shows the the impact on the taxpayer, both from the, what the proposed property tax rate will need to be, and also what the exemptions are, and any fees. Now, we don't have fees for central health, but is that what you mean? Will we be seeing a document like that so that the consumer can look at it and see, I mean, you can't predict for everybody, but on an average basis, the consumer can see what if it's up or down in terms of how much they'd be expected to pay next year versus their past year.
Right, so typically what we present is the average homestead
Yeah.
value. And then we also present bands,
Okay.
usually in $100,000 increments, just so, sometimes the average homestead value might be substantially different. So the bands, I think, allow homeowners or taxpayers to look at those bands and assess how they might be impacted a little around whatever their value of their homestead might be. And it's really more of a homestead taxpayer impact statement. So if there's any additional information that you would like.
Yeah, it would be good to also show the impact on seniors, for example, seniors and people with disability who also
Right.
have that other exemption.
Right.
So,
And we recently approved those amounts, so. and
So we know what those are.
Right, we increased those, so we can certainly show that calculation as it relates to, on the homestead exemption piece of it, we're at 20%, which
Yeah.
is the maximum allowed by state law, and we've been that way for potentially ever since year one.
yeah,
So 20% on the homestead exemption, and we just recently increased our disabled and over 65 exemption amount, but we can certainly show the impact of that also.
that'd be great. Thank you very
Sure.
much.
Thank you so much, appreciate it. Dr. Zamora?
Thank you, Chair. Since this is my 11th year in budget and my second to last year in budget, no questions, just a heartfelt thank you to Jeff and Lisa and their staff for their hard work. You do this incredible job every year, Jeff. Thank you. You and your team are incredible.
Thank you, and I think we all echo that sentiment as well. Thank you. Dr. Brinson?
I am wondering about this transition of the CCC costs in 2024. So we're going to take on the complete costs for CCC, and can you explain how that came about?
Yeah, so the CCC, the primary funding source were the Desert projects. And so the Desert program ended a few years ago. So it's been kind of a continual process to wind that down. So now the program has ended. Of course, our cash, the way our agreement is with with UT, our affiliation payment is the CCC is the payment source for that, and that's their first priority. So we've been winding the CCC. The CCC cash levels have been declining, and they will decline to basically zero at the end of fiscal year 2023. In the meantime, as it relates to 2023, and in years before, we've been moving the contracts that had been in the CCC over into Central Health, and that's been ongoing. And so this represents the final year that those costs will move over. And we're going to present the financial statements, I think, in the next item, and that, I think it'll give a little clarity to that.
Thank you so much.
Sure.
Thank you. Manager Valdez, you're online. Do you have any questions? I'm just going by order.
Yes, thank you. First of all, did I understand you to say that basically our budget is, and that's one of the reasons we have the contingency fund, is because our budget is not a balanced budget, but what in fact we have is increased uses over sources. Why do we not have a balanced budget? That's first and foremost. Then second, with respect to the equity plan, y'all have talked about including or proposed or possible 150 plus projects that we are going to be looking at. I don't know that that means that every one of them is going to be approved and included. So if we do or do not know, first of all, yes or no to that, whether we know exactly what projects are going to be included, because I don't remember seeing anything or voting on anything. And as such, then if we don't have anything voted on, then what is the estimate being used to include those costs for implementation of the equity plan if we don't know what those projects are? That's my second question. And third, what's an example of the unfunded mandates that we may be forced to comply with that the legislature, I'm assuming, will tell us we've got to do in the future? And then let's see, what else? On the tobacco litigation proceeds, do we just put that into our general fund, or does that go specifically to fund something other than our general fund? And if so, what? Then the
Well, do you want him to answer some of the questions that
I
you?
don't know, I can remember all those, so.
Yeah, because there's several questions.
Let me.
what I'll do is I'm going to go ahead and send these all to you, and I have others that I'll send these to you.
That'll be great.
At least for those that I have asked right now, I'd like to know an answer.
Sure. Thank you so much, Manager Valdez.
No
And if you
problem. Thank you.
can email those, that will be helpful as well. Mr. Canoto?
Yeah, so balanced budget. So one of the reasons we've been building reserves is we've known that as we're planning to make improvements to improve the gaps in our healthcare system, that our spend would be greater than the sources on an annual basis. So it's not a structurally balanced budget, but that's the reason we have reserves, because we know the spend will be greater than our sources. That's why we've been building our reserves up. That's why we want to also close the gap at the end of the forecast period and end up with a sufficient level of reserves. So yes, Manager, you're correct that our spend is greater than our revenues in the upcoming year, but I feel like that's been planned for and hopefully isn't a surprise. As it relates to the healthcare action plan, There was a presentation last week that had estimated cost. There's a presentation next week related to board consideration of approving those. So while they haven't been approved to date, we use the numbers in the plan for forecasting purposes, but hopefully it resonated that we have a budgeting process that has plenty of opportunities to make changes during the fiscal year 24 budgeting process.
So with that, I know the chair of that committee is present. Dr. Prince, do you want to comment for a minute about that item, or do you want to wait until your meeting?
I think we'll wait until a meeting, but I don't have any comment to make.
Okay,
Yeah.
thank you.
So we simply use the amounts that were presented as a way to estimate future costs and then to ascertain if we were sustainable over the forecast period. As far as unfunded mandates, I can't give you an example of something that's coming down the road, but there's always a risk that local government is required to do something from the state or federal government that the funding doesn't come with it. I will just leave it at that. That's just always a risk that's out there. I'm not aware of any current risks that are pending in the process. And then your last question on the tobacco proceeds, they are not designated for a specific purpose. They're just a revenue source. Central Health really just has one set of financial statements. All of our revenues go into the Central Health. It's really not the general fund, but the Central Health Fund, and then we spend them accordingly.
Thank you for that. Dr. Bell?
Now, I need a further clarification, Jeff. Your response to the, I can understand you saying Central Health does not operate a balanced budget, and that we do spend more money than we get, and that's supposed to be some justification for the contingency savings or the money that we're putting in the bank. But that's a different conversation as far as you and I can have on that, and maybe what the public can understand. But regardless, with respect to the project, the 150 projects, we haven't seen them, and I don't know. Well, having sat through the City of Austin evaluation of their funded entities through the audit team.
Manager Valdez,
there are questions
that
we need to have in front of us as a board, I would think, before we ever decide what projects we're going to approve. And there has to be a process for that, and we have to kind of get an idea as to services, direct services for medical and hospital costs for our targeted population, and or
point of order taken. Thank you.
So Jeff,
Manager Valdez, I just wanted to remind you, the last strategic and planning committee meeting, we had how long was that presentation? About 2 hours, I felt, that meeting. They went in detail with the proposed projects and estimated costs.
I just would like to know whether or not we can get that synopsis. That's all.
So we can forward you that presentation. So staff will forward you that presentation. Thank you so much. Appreciate it. And we'll follow up with those questions that you have as well via email. Thank you.
I appreciate it.
Thank you. Dr. Bell?
Thank you. Actually, Manager Valadez asked my question, and Jeff, you answered it in saying that you used estimates from the previous presentation that we had with regard to the initiatives under the Health Equity Plan to be able to get some idea of where we will be as we spend into the future. And so, thank you for that. One other question, and this is just for my clarification, is there a percentage that we cannot go above with regard to the tax rate?
So the answer is no, there's not an amount that you can't go up to, but if you go above 8%, it requires a vote of Travis County voters. And that's what we had back in 2012, 2011, was that. So anything above 8% would require a vote.
Okay, thank you very much.
Thank you. Did that answer your question?
Yes, it did.
Thank you. Manager Jones?
Yeah, excuse me, I have just two quick questions. One, and they sort of follow off of Manager Valadez and Dr. Bell's question, as it relates to health equity, and we're looking at a budget for a certain amount. Is embedded in that the current funding that we're presently providing, and is it built upon that, or is it going to be some development of a combination of other programs that may come in based upon a certain amount of money? For instance, forgive me, let's say $100 million going for health equity. Will we have the opportunity to change that as we look into the budget for next year, or are we going to have a base budget of what we currently spent this year and we're going to add to that?
Answer that. So the way that we built the forecast and is we looked at, well, I'm just going to call it the base budget. So think of that as fiscal year 23, and then we looked at what increases occurred in that base budget. And then we took the healthcare equity plan, and those are considered, starting in fiscal year 2024, new costs. And so we've added those costs on an annual basis, and every year we've accumulated and aggregated those costs. So they're ongoing costs, right? So, for example, if the first year is $30 million, and then in year two, there's an additional $20 million, you would see in year two, $50 million, so that we're adding those up as ongoing. So, so those were what was incorporated into, again, the forecast. It might look a tad different on the budget, just because we're going to get into a lot more detail on the budget, but just aggregately, those were the two, kind of think of them as spend items that we delineated in the forecast.
Okay, so would it be fair to say that the initiatives that have been started already under FY 2023 will assume continue in FY 24 and maybe 25 when we get around to that as part of the base budget?
Yes.
Okay.
Yes, and they'll be incorporated into the budget process that the board deliberates
Okay.
and eventually approves.
Okay, so I just want to be clear about that one. The second question, and forgive me, this is my naivete, does the proposal that the governor signed off on tax reduction and homestead exemption and tax rate, how will that impact, if at all, us as a district?
I don't think it impacts us related to the homesteads.
Okay, so those reductions do not affect healthcare districts? Hospital districts, I'm sorry.
Right, the way that it's structured, I don't believe it does. And if it does, it's a very immaterial impact. Sorry, I was out when all that happened, and I haven't had a chance to go back and read. But it's either going to be anywhere from 0 to immaterial. So.
Okay then. All right. Thanks very much. Those are my questions.
Thank you, Manager Jones. Management Maloney?
Thank you so much. I really don't have any questions. It's very clear. And it's also clear because I've seen these projections over and over in the years that I've been on the board. And I just applaud you all for being able to make such, of course, there's variance in the projections, but accurate projections, first of all, that are well informed, and secondly, revisit them and continue to calibrate them, inform us about it, to a point where I don't have questions about it. And I can certainly appreciate the nuance of perhaps not having positive net revenue, on the balance sheet, and you know, when you're looking at over a decade period of planning where we know that our reserves are effectively one of our revenue sources because we've planned it that way, I see this, you know, I see this as a very, very, maybe non-technically so, but balanced and extremely well-planned budget and exercise. So thank you all so much.
Thank you, Manager Mitwani. That's a great segue to end this presentation. I really appreciate you all and your hard work, and this really emphasizes our commitment to our community, providing the services that we have promised and they have asked for several years. So our commitment to address the health needs of our underserved and uninsured community members. Manager Kitchen, is it quick? Go ahead.
Really just a quick process question.
Yes.
So, my understanding that is that next week we'll get the Health Equity Action Plan. That's the time to ask any further questions that we might have about it, or in between now and then, or submitted them. And that at that meeting next week is when we are expecting to, I want to use the word approve it. I don't know if technically, huh? Prioritize and ratify it, is that the right word?
Yes.
Okay,
Prioritize it and ratify it. That's
okay, just wanted to confirm that.
prioritization. That's correct.
And as I mentioned early on, this is just a start, and if you have any questions, you can contact,
Yeah.
always send them down to Brianna and she can forward it to the appropriate individuals, but this is really an ongoing discussion, and as mentioned earlier, it may change differently, but I just also want us to be cognizant of our commitment, and also we don't want to add an additional burden on our taxpayers. So just be really cognizant on that fact. So, did that answer your question?
Well, I just want, my question really is, when do I have the next opportunity to state that I may have a thought about changing the health equity plan to some extent? So my understanding is that that is next week.
That's correct.
Correct.
Okay,
Yeah, if I can, we got some of your questions.
Okay.
We plan on addressing those
Great.
next week and next week.
Can you send those before the meeting? At least you have some.
No, we have them.
To answer those,
Oh,
answer
yes.
Manager Kinchin's
Yes.
questions before
Yes.
the meeting, so she can have an opportunity to review it.
Absolutely.
thank you.
Thank you, Manager Jones.
Yeah, just one quick question related to what Manager Kitchen just said. So in my questions a while ago, I said their base budget for health equity, we have sort of a base budget, is that correct?
Yes.
Yes, in the forecast,
Right,
yes.
okay. So if we're gonna build upon that, or we're talking about changing what's in the base, is that where we're headed and for our discussion? Because my understanding, if you have a base budget and you're building upon that, what you had before, you will continue on, you'll add to that. So I'm trying to get some clarity in terms of where do we go? How are we approaching that?
By base budget, do you mean what's presented on August 9th?
Yes.
Yeah,
So I can, base budget is fiscal year '23.
Right.
So I think your question is, can you make changes on anything moving forward? Absolutely. You have
Yes.
discretion to, if there's something in, quote, the base budget, and it's fairly minimal, but yes, there are opportunities to discuss that.
I was just gonna say, if the assumption is that the community is getting what we wanted from this. If we're going to start making major changes in it, that may impact the outcomes of what we're looking for. So that's what I was trying to say. We're gonna have a deliberative discussion about what we've got, what we're getting from health equity plan, and what things we need to get. So I don't want us to change things that we already developed.
all I'm saying is that we vote on the budget on September 6th, and we have an opportunity as a board, once that budget is presented to us on
The ninth.
August 9th, if we want to propose an amendment to the budget, we have an opportunity to do that.
Right. I think we're saying the same thing. It's just,
Yeah, we're saying the same thing. I just want to put that on the record because I don't want to have the conversation now because I want to have the conversation next
Right.
week. I like what we have with the health equity. I'm not talking about presenting anything that would cause any kind of difficulties with that.
Understood.
I might want to spend more on a few things. That's all I'm talking
So-
about.
And same here, that's where I'm.
That's
So
what I'm
to
talking about.
answer everyone's question, yes, you do have an opportunity, and it's ongoing, and nothing at this moment is set in stone. So every board member has an opportunity to express their voice. Dr. Bell, did you have something?
I think they're clear. I was gonna throw something in there that hopefully would clarify, but I
Okay.
think they're clear.
Perfect, so I think we can,
Manager Val.
Manager Valdez, is it quick? Because I need to move on to the next
It
agenda.
is quick if I'm allowed to finish. Thank you for presenting the budget or the proposed budget, Jeff. I just want to make sure that you understood that what I wanted is the details on those projects, and that we would all as a board. I don't know if they all would want, the members would want a copy of that, but I do want a copy of that so that I can look at that and review it so I'll be prepared for next week's meeting.
Okay.
That's all I want to say.
Perfect, we'll do,
And to add one last thing, and that is that we also take into consideration increasing the amount of money for covering and increasing the number of MAP patients that we serve. Thank you.
understood, thank you so much. So Brianna, can you forward that presentation to Manager Valdez? Thank you. Members, I'm moving on to, there was no motion necessary for that item. Moving on to item number 3. Receive updates on the preliminary May and June 2023 financial statements, including capital projects for Central Health and the Community Care Collaborative. Presenting is Jeff Canodal and Patty Petsky will be present. Thank you. The floor is yours.
Thank you, and good evening, Budget and Finance Committee. I'm Patty Bethke, the Controller, and I'll be presenting the June Central Health financial statements. The May statements are also in your packet, but we'll focus on the June financials. So, jumping right into the balance sheet page. Thank you. We have a strong cash position with cash at $528 million. And our total capital assets are currently at $151 million. And our total assets are at $1.2 billion. In our liabilities, our total current liabilities are about $25 million. And we're holding funds for the LPPF at $2.8 million. And we have no other significant changes in the other liabilities. So our total liabilities are at $384 million. Our net assets are at $779 million currently, and that gives us a total of liabilities and net assets of $1.2 billion. So moving on to our sources and uses. You'll note that property tax revenues are at $278 million currently. And while our collection rate, sorry, I was back on this last page. Our collection rate is currently at 97.5%, compared to last year when we were at 98.4%. So our collection rate is lower, but if you'll note that our total sources compared to budget are 104%. So our collection in gross dollars remains high, even though it is running slightly behind last year's collection percents. In our uses of funds, our total uses of funds for the month were at $18 million. That's made up of about $15 million in healthcare delivery program. It is increased due to recent increased activity. And that puts us at $135 million year to date. Our total administrative program costs are at $14.7 million for the year. So that gives us total uses of funds at $149 million year to date, and an excess of sources over uses at $164 million. And moving on to the next page, you'll also notice that we've included some supplemental schedules, so we're not here the last time we presented. And these are providing you the same information that we used to provide previously from our previous accounting system in a slightly different format. We'll continue to refine the report details, but we'll the details will be included moving forward. And so under healthcare delivery, we'll continue to outline the purchased healthcare services and the direct healthcare services and our expenditures for MAP and eligibility, as well as the premiums we're paying for ACA, our healthcare facility spend, and the healthcare delivery operating costs, and our debt reserves and interest payments due. And then on the next page, this is the specialty care page. And this outlines the details that were summarized on the previous page under specialty care. We'll continue to refine this report as well. You'll notice on this report that we've included down the left-hand side all of the specialties that we're working on, and a special note in orthopedics. We've rolled this into musculoskeletal, so that line will be rolled up in the next reporting cycle. Pain management is a newly approved contract, so we'll start seeing expenditures in that line in the future. And project access is included in the CCC's budget. They continue to pay for that one. And neurology is reserved for future planned services expansions. So are there any questions on the central health financials?
Thank you. I have a quick one. The healthcare initiative plan, that to me, can you elaborate more in terms of the funding? We have allocated like what is the status of?
So of the budgeted $1,750,000, we've actually spent $135,000 year to date on those programs.
So that is something that we as a board need to reconsider as upcoming budget, that maybe our outreach, or we're not reaching out, maybe we need to revisit that initiative.
What?
The community healthcare initiative, that we allocated almost 2 million in a way, and we only spent 100 million, and that, at 100,000, sorry. Thanks for thinking a lot about millions. But so I just want to pause at that moment for us to, yes, Monica, do you have something to share? Because I know there were probably a couple projects that were down the pipeline that we funded.
I think that those contracts are just recently distributed. And so what you're seeing are the expenditures that have been submitted so far, but that will increase as the year goes on, because I only think it was 2 meetings ago that we actually got a report on the community healthcare initiatives and the grants that went out. And so Monica, am I on the right track here?
Yes, Dr. Bell, Monica Crowley, Central Health, and you are absolutely on the right track. We have an evaluation framework set up around these projects. These contracts only recently did begin, so the vendors that we contracted with for these services are performing, and we will have an update and discussions about how we could potentially optimize these funds with maybe slightly different model in future years that we have taken from our learnings in how, if you really want to work with some of these smaller community-based organizations, how hard it is to set up contracts in the way that we have, and how we might want to follow some additional paths or update this program in coming years. So more updates to come on the Community Health Initiatives Fund project. But yeah, you're absolutely right, Dr. Bell. Thank you.
Thank you. I think that would be helpful and appreciative to other board members in terms of lessons learned and how do we optimize it in the future. Thank you. Any questions regarding Central Health's finances? So, Manager Valdez?
Thank you, and that was my question along the line. It was just basically a general question, because because I've seen that we're a little bit off on some of the budget amounts allocated. If maybe someone could give us a breakdown, even a little short synopsis, we don't need to hear it right now, about, why, like general surgery, it's already what, 177%, and other things are almost at nil. And I can understand if we just late starting on the initiatives, but I'd like to know what all those initiatives are. If
Okay,
you can remind us or send us out a complete list, I'd appreciate it.
maybe that's something staff can do later on. Okay, perfect. Well,
Yeah, they can do that during the week. Thank you.
thank you, appreciate it. Now, I don't see any further questions on this, on the Central Health finances. Can we move forward to the CCCs? Thank you.
We can, and I'll present it, and I'll try to do it quickly. I know we're running a little short on time. So the balance sheet, you see a comparative balance sheet, $12.7 million of cash. I want to talk a little bit about the liability side of it. So we have almost $9.4 million in liabilities. The deferred revenue number, that's always been a amount that we've set aside in the event of long-standing multi-year audits that HHSC's been performing related around the desert projects. We always held some of the proceeds back in the event that there was a recoupment. So in other words, some of the projects that we had that were ongoing around the desert program, the metrics were so thin that even if there was a slight error or unclaimed whatever the metric was, could result in at least a 25% recoupment of those projects. And as some of y'all may remember, some of those projects are fairly substantial. So we've always been conservative to set aside what we think were potential amounts or projects that had some risk to it, and decided that we would evaluate it on an annual basis, and then once the audit processes were complete, that we would release those amounts. So that time has come. So the $9 million that you see in deferred revenue in upcoming financial statements, you'll see that has been zeroed out. Where will it go? It will go on the next page, which the next slide. We will actually recognize the desert revenue. So it says under year-to-date, 0. We will actually recognize that in subsequent or future financial statements. So the question would be, what does it mean for cash? And my answer is absolutely nothing. So we've already received the cash. This is simply what's called, in accounting terms, a reclassification. So we're really, the audit period's over, we're recognizing that revenue, and it will show up on the sources and uses report. Another comment related around, can you go back to the slide? The other event, Manager Brinson, to get to your question a little bit, again, the UT affiliation payment is made out of the Community Care Collaborative. We budgeted $22 million in Central Health, and so if you're doing math to get to a $35 million payment, you would say, oh, the CCC must be paying around $13 million. I don't think we're going to have quite $13 million in the CCC, so there may be a slightly less amount of payment in the CCC. That payment's due August 15th. And then, of course, Central Health, as the guarantor of that payment, would make up the difference. So that concludes my presentation. If there are any questions, I'd be happy to answer those.
Thank you, Mr. Canoto. Do I have any questions related to the CCC budget? So I don't see any questions from any board members. Thank you. Really appreciate you both. I look forward to seeing you in the future meetings. Thanks for all you do. Thank you. So there was no motion necessary for that item. Moving on to our final agenda item, confirm the next Budget and Finance Committee meeting date and time and location. Managers, our next Central Health Budget and Finance Committee is tentatively scheduled for Wednesday, August 9th, 2023 at 1 p.m. at the Central Health Headquarters, 1111 East Cesar Chavez, Austin, Texas 78702. At this time, I'm ready to accept a motion for adjournment. Manager Matwani first and Dr. Bell seconds. All in favor?
Aye.
Aye, so we are at this moment adjourned.
Members, we do have food in the next room, so I'm gonna give you 5 minutes to go and get something to eat, and we'll be back in here by 5:30, okay?
Okay, thank you.
Good afternoon. Today is July the 26th, 2023, and it is 5:30 p.m. As a quorum of the committee is in attendance, I'd like to call to order the meeting of the Central Health Executive Committee. The first item on the item of business for the committee is public communication. We will receive public communication for both the Executive Committee and the Board of Managers meetings before we proceed to the Executive Committee meeting. Members of the public who wish to make comments during the public communication portion of the meeting must have registered with Central Health via the online form or by telephone no later than 2:30 p.m. today. Yersinia, did anyone register to make comments for either the Executive Committee meeting or the Board of Managers meeting? There were no individuals who signed up for comments. Thank you very much. We will proceed to the Executive Committee agenda. Agenda item number 1, approve the minutes of the Central Health Executive Committee June 14, 2023 meeting. Do I have a motion?
I move that we approve.
I have a motion for Manager Musaitis. I have a second for Manager Brinson. Any further discussion? Hearing none, all in favor? Aye. Any opposed? Any abstaining? Motion carries. Agenda item number 2, review and provide direction to staff on the prioritization and tentative scheduling of items for consideration at future Central Health Board and committee meetings. Brianna Yanis will be presenting.
Okay, so in your packet, you have a list of the tentative schedules. I'll go through August first. There are 9 meetings in August. So starting with the special called Board of Managers meeting on the 2nd, the items are Guidehouse and then a performance review update. And then on August 9th, we have both strategic planning and budget and finance. Strategic planning items are service reporting, tentatively a cancer care update, a ham update, and then a deep dive on FY24 strategic priorities. For the Budget and Finance Committee, we will have the FY24 proposed budget. Then on Monday, August 21st, we will have an ad hoc appointments committee meeting. And then on August 23rd, we will have 4 different meetings, starting with the medical committee meeting, a budget and finance committee meeting. At that meeting, we will have July financials, the proposed FY24 budget and tax rate, quarterly fiscal and operational updates from Sendero and CUC, and then a Sendero update, tentatively a continuation from our first executive work session. On executive committee, we will discuss research and survey reports and also have the performance review as a standing item. For the Board of Managers meeting, we will have a vote on the max tax rate and set the public hearing date, time, and location. And then on August 30th, we'll have a public hearing. And I have the community conversations listed here. Thursday, August 17th. I believe the August one I have incorrect. I think it's the 22nd, not the 21st. I'll update that and send it to you.
Okay.
And then August 28th. And then for September, we have a Budget and Finance Committee on the 6th, as well as Executive Committee and the Board of Managers meeting. At the Board of Managers meeting, we will vote on the FY24 budget and priorities and tax rate. And then I have listed also the Travis County Commissioners Court dates, which are scheduled for September 7th and September 26th. And that's all I have.
Okay, Manager Musaitis?
Yes, I may have missed it. I think this is something that we wanted to discuss about the CC community care structure. Is that, when are we going to be discussing that? And because of the reporting, if you recall that discussion that we had?
Governance?
Yes, for community care.
Actually, we're going to talk about governance from a
Broader?
perspective.
Okay.
But we can also talk about it, once we establish, it's an ongoing thing. So, and we have an agenda item for it today, but Mike was gonna be here and wanted to present it in person, not necessarily via the thing, so I'm just gonna talk a little bit about it, all right? But it'll be an ongoing conversation.
Okay, I would love to have that conversation.
Right.
Thank you.
And on the executive committee of the end of August, if you would put an agenda item to talk about, I don't know how to say it. It's getting rid of paper.
Okay. Okay.
Going green.
Going green. That's a better way to say it.
Okay.
All
Got
right.
it.
Thanks. Any other Manager Kitchen?
Oh, just wanted to let people know that we will have a succession committee meeting. We don't have the dates yet. We should have the dates shortly. We are waiting for the contract to be finalized. And so hopefully in the next few days, I'll be talking with Brianna about setting up the succession committee meeting.
Sounds good. And managers, as you can tell, August and September tend to be a meeting-heavy month. So mainly because of the budget, but also because of ongoing operations. So we really do appreciate your time and the fact that you provide the service that you do here at Central Health. Thank you. All right. Manager Valdez, I'm sorry.
I know, I'm not there, so you can't see me, but I appreciate you calling on me, Dr. Bell. I asked that we have a conversation, or at least if you put it on the agenda, so we can know where we're at historically and currently with the CCI. I don't know of very many board members that are even familiar with it. And then in addition to that, also a conversation on, and it's probably going to be an executive session. So I'm giving everybody a heads up with respect to increasing our MAP numbers and possibly looking at modifying the financial eligibility criteria. So those two things I'd like to have put on an agenda so we can discuss them.
Okay, thank you. Could you, Manager Valdez, what was it, PCI? What
do you mean?
CCI, okay. The Capital Area Improvement?
CCI, yeah, yes, remember?
Capital City.
Our last meeting, Capital. It was a UT Bethel, Central Health.
I got it.
Got it? Okay.
I got it. Thank you. If you'd make a note of that, Brianna, and remind me as we're putting the agendas together.
And also that discussion on MAP eligibility.
Yeah, MAP eligibility. Thank you very much.
Thank you. Thank you.
Manager Misaiti.
Really quick, isn't it MAP related to our Sendero item?
The map that I think she's talking about
Just wanted clarification.
is more about, and correct me if I'm wrong, but it's more about continuous eligibility, right, Manager Valadez?
Okay.
Right.
Thank you.
Did you have your hand up?
I just have a comment with regards to our board meetings, and maybe the executive committee can make a recommendation to the board. If we look at, in light of what has just been said, as a support for our board members participating, being involved, being engaged, in particularly during the summer and even the winter months, we talk about timing and holding ourselves to certain limits on that, and if what can be done to moderate the amount of time we spend in discussion. We want to hear everyone's comments, but we have to be reasonable about this. So are there strategies we can come up with that the executive committee maybe could recommend to the board that we inculcate in our meetings in terms of our presentations? I won't give any recommendations this time. I would just encourage the executive committee to consider doing that.
We can have a discussion about that and see what recommendations and strategies members may have with regard to that. Thank you very much. I appreciate it. Manager Valadez. See, I saw you this time.
I thank Manager Jones for bringing this up, but maybe one of the things to consider also is for our newer board members, for them to really get an in-depth overview of things that have happened historically, and then where we're at currently, so that they won't be asking 10 million questions about what this is and whatever. I think that is, they have every right to know exactly why we are having such discussions and why they're important. But I think sometimes maybe they didn't have the sufficient background information provided to them during the orientation. So
Okay.
maybe that's something we can look at. Thank you.
Thank you. Thank you, Manager Valadez. Okay, agenda item number 3. Discuss and take appropriate action on oversight of Central Health funded entities and others to which Central Health Board appoints governing and advisory members. Members, Mike would be presenting this. He has asked if we could postpone this until the next meeting so that he could be here in person to present it. You do have documents in your backup that sort of outline his discussion. So if you want to read that and prepare for the discussion next week, you're welcome to do that. But we will be talking about this item at our next executive committee meeting. And Mike, we wish you a speedy recovery.
Thank you.
Agenda item number 4, discuss updates on the performance review contracted for by Travis County, including delegations to the president and CEO to execute necessary agreements between Central Health, Travis County, and Mazars USA. Mike?
Yes, thank you, Dr. Bell. Members, we are awaiting a revised interlocal agreement to be sent to us that then we can review to make sure that it addresses the board members' concerns that have been expressed when we last reviewed the document or the proposals. And so what we've done is we have put a placeholder agenda item on the August 2nd meeting so that if we do have a document that meets the board members' criteria, that we can get the approval to execute on that document. But that's where we are right now.
All right, thank you. Any questions? Manager Musaitis?
I have a question. If we're still debating, like we're still in negotiation on this item, and what if it takes a little bit longer than anticipated time for this performance to be done, and Central Health has its own mandated performance, the third-party performance? Is it every 2 years, our internal one?
It's every 5.
Every 5. So what if we lapse the 5-year performance? Is there any penalties on the district? I'm just curious on that issue.
Mike, you can correct me on this or not, but I don't think that our performance review, the actual implementation of a performance review is in law. Am I correct on that?
That is correct. The performance review is mentioned in the financial policies that have been adopted by the Travis County Commissioners Court for Travis County Healthcare District. And in the recent, I can't remember if it was the procurement document or the resolution adopted by the Commissioners Court, they noted that this particular performance review would satisfy, once it's completed, any requirements for the periodic performance review. So we're not in violation of or have any kind of regulatory risk on this.
Thank you, Mike. Thank you, Manager Musaitis. Any other questions? Seeing none, agenda item number 5, confirm the next regular Executive Committee meeting, date, time, and location. Managers, our next Central Health Executive Committee meeting is tentatively scheduled for Wednesday, August 23rd, 2023 at 4 p.m. or immediately after the Budget and Finance Committee meeting at Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. At this time, I'm ready to accept a motion for adjournment. I have a motion from Manager Brinson and a second from Manager Musaiti. Any further discussion? Hearing none, all in favor? Aye. Any opposed? Any abstaining? We are adjourned. Managers, I am going to allow our presenters to come on in, and then I'll start our Board of Managers meeting. Hi there, how are you? We have some formalities to take care of, but you can have a seat. You're first on the agenda, so. Good evening. Today is July the 26th, 2023, and it is 5:47 p.m. As a quorum of the board is in attendance, I'd like to call to order the meeting of the Central Health Board of Managers. First item of business will be the consent agenda. Consent agenda C1, approve the minutes of the Central Health Board of Managers meetings June 14th and June 28th, 2023 meetings. And C2, receive and ratify Central Health investments for June 2023. Do I have a motion?
I move that we accept the minutes of the Board of Managers for June 14th and June 28th of 2023.
I need the consent agenda items.
Consent agenda items 1
And 2.
and 2.
There you go.
I second.
I have a motion from Manager Brinson. I have a second from Manager Musaiti. Any further discussion? Hearing none. All in favor?
Aye.
Any opposed? Any abstaining? Motion carries. We will now proceed to the regular agenda. Agenda item number 1, receive an update from the University of Texas at Austin Dell Medical School on the current and future collaborations with Central Health care and services provided consistent with Central Health's mission and related reporting for the current fiscal year. Dean Claudia Lucinetti and Michael Murray from Dell Medical School will be presenting. And Dean, welcome.
Thank you.
We're so happy to have you here.
Thank you. So first of all, thank you. I'm Claudia Lucinetti, I'm the Dean of Dell Medical School and the Senior Vice President of Medical Affairs at the University of Texas at Austin. This is the first opportunity I ever looked at after a long 27-year career at the Mayo Clinic, where I was a practicing neurologist, chair of the Department of Neurology, and dean of clinical translational research. And in those capacities, and in that capacity, in my time at the Mayo Clinic, I've enjoyed my career there, but I was in particular drawn to the mission of Dell Medical School and its strong focus and commitment to want to advance and improve the care of our safety net population and the community at large.
And within that context, I've been here, as I said, about 7 months, and I'm really honored to have the opportunity tonight to give you an update of where we've been at. It's a taste of where we've been at. There's much to talk about, and much we want to cover, but we will go through that presentation. I am joined by my colleague here, Mike Morey. He's our Chief Administrative Officer at DelMed and the Chief Healthcare Strategist for the University of Texas at Austin. Mike, how about you introduce yourself?
Thank you. Really thrilled to be here. Thank you for having us this afternoon. My name is Mike Morey. I am the Chief Administrative Officer, as Claudia pointed out, of Dell Medical and UT Health Austin, as well as Chief Healthcare Strategist for the University of Texas. I've been in my role 7 weeks now. I also came from Mayo Clinic, where Claudia was, and I worked at Mayo Clinic and in healthcare for 28 years, served a variety of roles in that capacity, ranging from departmental support to outpatient operations and international. But more of my recent experiences were in our Mayo Clinic health system sites, which are community-based systems in western Wisconsin, and have a draw actually to serving the communities. And you can imagine there's more of a rural population, but some of the underserved issues still remain the same. I was drawn here to the University of Texas and Dell Medical for many of the same reasons Claudia was. The orientation around the mission to provide outstanding patient care, to serve the underserved. And then lastly, I should mention, my accent wouldn't hint at it, but I am actually a native Texan. I have family here in Central Texas, and I know the importance of establishing a strong medical care for the citizens of Central Texas. So thank you.
So it's a pleasure to be here tonight to engage with you more about the progress and impact of our partnership that we hope will continue to benefit our Travis County communities and our local safety net population in particular. Before we begin, I want to thank Mike Giesling, who I know is able to join us tonight, and Chairman Charles Bell for both of your ongoing partnership in this important work. I also want to thank all of you for your service as Central Health Board members and for the thoughtfulness that you each bring to your roles. And lastly, I want to thank our many partners throughout our city, the state, and the nation. Our work is inherently collaborative. One of the things I carried with me from the Mayo Clinic is the quote, "It really takes a union of forces to care for patients." And here I would say that this is our union of forces. I think that we have, this work really doesn't occur in isolation. It's successful as being really collaborative and done together. And as you'll be hearing tonight, we'll have a lot to be proud of. However, there is still quite a bit of work to be done to address the gaps in our safety net population, and it's going to take all of us working together to continue to transform health and healthcare in our community. So before I get into the presentation, and I think the next slide is up there are a couple of important points I want to make. The community's visionary investment is substantial. We recognize that it is foundational to Dell Medical School. In addition, that investment is actually incredibly generative. It creates impact well beyond the $35 million annual investment. There are many examples, and tonight we're just going to be sharing some of those examples with you and look forward to discussing them further. DelMed is focused on becoming an anchor of an integrated academic health system where we can bring expertise and investment in clinical care, in research, and in education that are uniquely combined with a real focus on bringing impact to the community. We'll continue to work with partners like Central Health to improve health and healthcare for everyone in Travis County, and we're continuing to invest in efforts such as clinical services and residency programs as a reflection of that partnership. Going forward, our intention is to focus on working strategically and collaboratively with Central Health to really address the gaps in the continuum of care for safety net patients and families across prevention, health access, health disparities, and quality. And that continuum includes a focus on disease prevention, improving access to specialty care, and we'll be talking about that a bit more, creating a system of seamless, high-quality health care, understanding the challenges of navigating that care system, and addressing gaps in that specialty care, where we believe that Dell Medical School can continue to be a strong partner with you. We'll talk about a bit more of that a little bit later. So for our next slide, first, a few notes to focus our discussion. The DelMed Central Health Affiliation Agreement, signed 7 years ago, specifies that DelMed will receive $35 million annually for 25 years. And it also specifies permitted investments of this funding. Mike?
Next slide. This is a summary, of the affiliation agreement and its effects produced by Mike Giesland. And it was shared with the Central Health Budget Committee in May. I'm sharing it with you tonight to know a few things with this. Number one, the permitted investments discussed in the agreement is the provision of direct operational support to the University of Texas that will be used by University of Texas in its I guess we're jumping back. An essential aspect of the affiliation agreement and the permitted investments is the direct operational support to UT and UT's discretion to facilitate and enhance a few things. One is the development, accreditation, and ongoing operation of the UT Austin Dell Medical School. Its administrative infrastructure, which, by the way, we're in the midst of preparing for a liaison of medical education groups accreditation for next year. For recruitment, retention, and work of University of Texas Austin Dell Medical School faculty, residents, medical students, researchers, administrators, staff, and other clinicians, and other related activities and functions as described in recitals of the agreement. Now, I'll add to that part of that agreement also outlines a provision of care and system contributions that include things such as research and fellow programs that we encourage our individuals that participate in those programs to stay in Austin and serve the Safety Net community, a comprehensive range of programs and services made available to the community, which we'll cover later on, and then service-based research, which we'll also cover in our presentation tonight. And then, next slide, please. With respect to the ongoing reporting required as part of the affiliation agreement to Central Health and agreement with Central Health, we've agreed on a number of variables around patient statistics, patient volumes, patient demographics, as well as quality metrics. Things like return to the OR for surgical site infections, inappropriate hospital transfers, patient-reported outcomes, patient experience measures. That's part of this reporting aspect. Now, those are the legal lines of our partnerships. Next slide, please. And having reviewed them and working with you all today in our shared continuing commitment to them, we're really excited to talk about tonight is our shared goals. And what you have here is, you should be familiar with this, is a great illustration of the integrated care delivery system that was included in Central Health's own service delivery strategic plan. This is where we're headed as a region. This is where we're headed as joint organizations together, and we're very proud to be actively contributing to this network of care. We've also highlighted those areas which we play a role in this integrated care, but as integrated model of care. But as Claudia pointed out, we have so much more to do as well. Next slide. Within this system and within the safety care network, we have many, many partners in addition to Central Health. And they include Community Care, Austin Public Health, Integral Care, Lone Star Circle of Care, our philanthropy partners, et cetera. One of our greatest strengths as a system is to leverage the strength and expertise of each of what our partners bring to the table. I'll turn it over to Claudia to talk about our progress as partners over the last several years.
So we have a timeline here to kind of give you a sense of what at a high level has been accomplished over these years. And so we began educating our medical students in 2016 after taking over sponsorship of existing graduate medical education programs, which train physicians in either a specialty or subspecialty. That was in 2015. We actually opened UT Health Austin, which is the clinical practice of DelMed, where more than a third of our patients use MAP, Medicaid or Medicare, in 2017. That same year, the first master's agreement with Central Health included musculoskeletal and women's health care. Next slide. In 2018, we began a collaborative redesign of the Austin State Hospital, and that's expected to open next summer. A facility that's going to be serving 38 counties for adults, 57 counties for adolescents, and 75 counties for children, along with the continuum of mental health care. In 2020, we worked very closely with you all to respond to the COVID-19 pandemic. co-creating a COVID Center of Excellence at Del Seton Medical Center that at one point had Del Seton's patients surviving at twice the rate of our other COVID-19 patients across the country, and working closely with the city, community care, ECHO, and others to ensure that COVID care and other supportive services would be available to our patients and people experiencing homelessness. By 2020, we had doubled the number of GME programs. Those are the graduate medical education programs over the count. We first started sponsoring in 2015, and this year we've actually tripled that mark. We now have 442 DelMed residents and fellows providing care to more than 575,000 hours of care to patients at over 60 clinics and hospitals, with 78% of that care provided in a safety net clinical environment such as community care. In 2022, Central Health launched its healthcare equity plan and announced the appointment of one of our own faculty, Jewel Mullen, as Director of the Health Equity and Quality. And we've been privileged to be part of so many important firsts. For example, here in Central Texas, including the first pediatric heart transplant in 21 at Del Children's and the first pediatric kidney transplant in 2022. Next slide. Now, bringing together world-class care to Central Texas or to any region is one of the things that academic medical centers are well positioned to do. And academic medical centers, particularly ones aligned with top research universities like the University of Texas here in Austin, can attract these faculty who wield national influence. But that's not the whole point. To have national influence means you can then also recruit other doctors and bring them here to Central Texas to provide care to all of our patients. Like most doctors at DelMed, our doctors also spend quite a bit of their time providing safety net care, including care for MAP patients. And as you see here, 5 of our 13 department chairs are presidents of their medical specialties at the national level. So they have a voice, not just for their specialty, but for the community and for the underserved. Next slide. Now, as we get some data, but we'll just share this with you, a lot of numbers, but since 2014, DelMed is directly or indirectly connected to attracting these 449 new doctors to Austin. This represents actually today about 10% of Travis County physicians, and we expect that to continue to grow. On another point, of all faculty members employed by DelMed, 81% work full or part-time in the community with a range of clinical partners, which we'll talk about in a few minutes. And from these physicians and their teams, we've gained care capacity that ranges from basic to complex, including advanced pediatric care by Chuck Frazier, care for fetal medicine for the highest risk pregnancies, more abdominal transplants, and including services previously not available here and highly sought after. I would now like to introduce Dr. Jane Edmond. She is the Dell Medical Chair of the Department of Ophthalmology and the Director of the Mitchell and Shannon Wong Institute at UT Health Austin. As President-elect of the American Academy of Ophthalmology, she's one of those top doctors attracting top teams to bring new, more, and better care to Central Texas. And we've invited Dr. Edmond to speak to you for a few minutes tonight about the specialized ophthalmology services and care she provides and how this and her vision for high-quality safety net care is being established.
Thank you, Claudia.
Jane.
Thank you, everyone, for allowing me to be here. What attracted me to Dell Medical School to serve as the inaugural chair of the Department of Ophthalmology and actually the first employee of my department to begin a department from scratch was twofold, and it's pretty much 50-50 equal percentage. One is, as Claudia mentioned, the compelling mission and vision of our school, which is very unique compared to other medical schools. But the other 50% of my passion and commitment to come here and interest to come here was to serve the safety net population of Travis County and provide the highest quality of care for our safety net population. And in fact, of all of my mission and vision statements in the first, actually all the 5.5 years that I've been here have always included as my 5 top priorities, expanding care to the safety net population has always been one of those 5 top priorities. And as a academic pediatric specialist for 32 years now, I'm trying to stop counting after 30. My patients, 50% of my patients have always been within the federal poverty limit. So that's what we do as pediatric specialists, and that's what I think illustrates my commitment to the care of safety net population. And as Claudia mentioned, I represent a rare specialty of pediatric neuro-ophthalmology. And I'm the only pediatric neuro-ophthalmologist accepting new patients in Texas. One is sort of semi-retired, one in the military. And I routinely see children with brain-based disorders from all over Texas, Dallas and Houston for sure, and even outside the state. And as chair of the ophthalmology department, my strategy to expand care to the underserved has been multi-pronged. One is to build partnerships with community care clinic. Ellen Shalsha met me the first months I was here as chief medical officer, a partnership with Central Health, and recruitment of mission-aligned faculty. I've hired 4 faculty into DelMed. We have lots of affiliate faculty, but 4 faculty now, including myself, which is 5th, 2 more to come soon. And the creation of a residency program to train the future leaders of ophthalmology and inculcate in them our mission to care for the safety net population. I want them to be socially conscious so that when they go into private practice, they will continue care of these of our patients. My second slide, just a patient story. We see patients with that are covered with MAP and MAP Basic, the only comprehensive ophthalmologist who's care for patients with MAP Basic coverage. And this was a patient that was seen in our resident clinic. We have 2 residency classes. And in our resident clinic, this was a 51-year-old man with MAP Basic insurance who had had a lifelong poor visual acuity. He could not even see the big E in either eye. 51 years old. Glasses had never helped. He had seen an optometrist who referred him to our clinic for cataract surgery, for feeling cataracts were the issue. Cataracts were not the issue. It was a very mild state of cataracts. But assessing the prescription of this individual, he was minus 29 diopters of myopia or nearsightedness. Average, like me, I'm minus 3. It's very hard to assess those gigantic prescription errors. He had never been given the right glasses, ever, in his whole life. So we prescribed him his minus 29 prescription, very thick glasses, 20/50 vision, first time ever. So, and this is sort of jokes me up, but he wrote this to us, and it was in all caps and in Spanish, so I hope we translated it properly. Thank you for your patience and for being so kind. You made me feel very good. All the staff are earthly angels. God bless you forever. So that's what we can do together.
I heard that too, that part.
That's somebody I have to call after.
All right, thank you. Thank you so much, Jane. Thank you for taking the time to be here tonight, and I think you can really see and understand how deeply personal and how this is embedded in her professional career and for many of our physicians within the Dell Medical School. Next, we're going to review some of the permitted investments under the affiliation agreement, noting important areas of work now and into the future. So that's on slide 15. And first of all, let's talk about how we're integrating care and services to improve the health of the safety net population. So I'll move to the next slide, slide 16. Thank you. Here's our current state.
My name is Donna.
Here's our current state. In the last year, 8,917 unique patients at UT Health Austin used MAP, Medicaid, or Medicare. That's overall over a third, about 36% of all the patients that we see at UT Health Austin. About 12% of all UTHA unique patients use MAP, 5% use Medicaid, and 19% use Medicare. And of the Medicare, 967, or 4% of our total unique populations, are estimated to be part of the safety net population. One of the care team members at UT Health Austin is Donna Shanor, a social worker who leads the clinical group. Via video, she's going to tell us a little bit more about her work and why it's so important to the safety net population. Now you can start that video, please.
Hi, my name is Donna Shaner. I'm a licensed clinical social worker, and I am the Associate Chair of Clinical Integration for the Department of Health Social Work here at Dell Medical School. Social workers provide many different services like case management, where they are connecting patients to different resources, whether it's transportation or housing or medication. They provide psychotherapy services, mental health services to our patients. They help with patients and give them psychoeducation on a medical diagnosis and understand what's happening through the navigating through the medical system. There are many, many therapists available in Austin Travis County. What's not as available to patients within our safety net or patients who have MAP or Medicaid or Medicare is our mental health services, because many of the therapists in town will not accept Medicaid, MAP, or Medicare. And so access is definitely an issue. And our patients are able to access that care here. I can give you an example. We had a patient come in who came into one of our specialty clinics, was seen by the medical team, and came in for chronic pain. The medical providers and the care team realized there were some other stressors going on with this patient, and they weren't able to identify a physical explanation to this chronic pain. So they were able to refer over to a clinical social worker same day. And this clinical social worker met with the patient and was able to determine that they had experienced a traumatic loss of a child, and were having chronic pain. They did the social worker did an evaluation and was able to also to determine that they had post-traumatic stress disorder. This was a patient that was monolingual, Spanish-speaking, had MAP, and so this clinical social worker was able to provide evidence-based treatment specifically for PTSD. And 3 months after treatment, or through the three months of treatment, when that was complete, the patient did not meet criteria anymore for PTSD, and the chronic pain subsided. This patient came back many months later for another small issue, and the patient reported that they no longer had chronic pain. They still did not have any of the symptoms of PTSD, and described being able to better care for her children. Another factor that was really important in this case with this patient was that our patient was Spanish speaking, and she was able to work with our clinician who was also Spanish speaking. So it's incredible value to the patient to be able to access mental health services in their native language. Over and over, our patients tell us, and we hear from our social workers, that they really have created a space for our patients that are navigating a system through a chronic illness, a physical condition, and many times a mental health condition as well. And they have several barriers going on, whether it's transportation, housing, access to care. And so to be able to sit with a social worker and help them kind of map out how to navigate the system and how to address those barriers in a way that's individual to them is of incredible value to the patient and to our care team in the way that we provide care here.
Thank you. Next slide, thank you. So now we're going to take a look at one of the areas of care MAP patient access at UT Health Austin has been expanded, and that is in musculoskeletal. In the last year, 50% of unique patients, about 3,128 at the Musculoskeletal Institute at the UT Health Austin, used MAP, Medicaid, or Medicare. And by this measure also, from the Medicare population, about 227 of 1,113 were treated at MSK UTHA, were part of the safety net population as well. So you can see the totals there for that particular service line. If you go to the next slide, please. For women's health, in the last year, 29% of unique patients, about 1,359 at the Musculoskeletal Institute at UT Health Austin, at the Women's Health, used MAP, Medicaid, or Medicare. And here you see the distributions there for women's health. Next slide. The work at UT Health Austin and work like Donna's are just a couple of the ways we have the opportunity to improve and integrate care. Of 323 faculty members employed by DelMed, 262, or 81%, as I shared earlier, work either full or part-time in the community with a range of clinical partners, including community care, Ascension Seton, and Integral Care. This year, they are contracted to provide nearly 400,000 hours of care. And you can see here, they provide care across primary care, cardiology, gastroenterology, neurology, and psychiatry. Next slide. At the same time, our 442 residents and fellows provide more than 575,000 hours of care each year, as I shared, at 60-plus clinics and hospitals. 78% of these hours are at community care, Del Seton, Del Children, or Ascension Seton Shoal Creek. Next slide. Now on this slide, you're seeing that in Williamson, Hayes, and Travis counties, this is where our residents and fellows are located. The burnt orange zip codes have practicing residents and our fellows working at clinics and hospitals. Meanwhile, our second and third year medical students in blue here participate in the primary care, family, and community medicine clerkships. This blue pinch drop shows where they have, since 2017, met with more than 20,000 unique patients, conducting more than 24,000 plus patient visits, and spending over 6,000 hours with our patients. So, next slide for Mike.
So what's next with respect to integrating care and improving care? Some of the action and analysis planning that we've begun to work with and build on the partnership that we've had is continue to co-design a selection of clinical practice delivery models and co-developing enhanced analytic capabilities to better assess the impact across the care continuum for MAP patients. There's new master services agreements in place for ophthalmology, reproductive care, surgeries by central health employed podiatrists, post-acute sequelae of long COVID, advanced imaging, and other opportunities you heard as an example in social work. We're also working on new master professional services agreements for the co-recruitment of between Central Health and DelMed faculty for in the areas of rheumatology, GI, neurology, and pulmonology, and we're completing the last aspects of that master services agreement. Now, I saw John Morgan walk in. We're working with him to do that. We're continually measure patient volumes, patient demographics, and patient quality indicators along the way.
So another permitted investment that's core to who we are, and we've been talking about here, is an emerging integrated academic health system, is innovation, education, and training. So on the next slide, we'll show you some quick statistics here. We have, up until now, 13 academic departments, 14 centers and institutes, over 80 UT Health Austin clinics and partner programs, 717 faculty, 891 staff, 442 residents and fellows, and over 200 students. Next slide. We hope to also expand the health career workforce by moving upstream from the MD and providing support and exposure and access to students across Central Texas. Through our pathway programs, we provide students with understanding of what it takes to succeed in health, build confidence and support, and the ability to become health professionals. So 6 programs currently serve over 500 students from high school all the way through to undergraduates per year. And to date, our Pathways programs have introduced 4,500 middle and high school students to careers in health sciences through educational activities and mentorship with health professionals. And that is just one statistic. Next slide is, I think we're one ahead. Stay on that one, please. Thank you. 187 students have now completed our signature MD program that's focused on teaching value-based care and health system science so that they're equipped to transform health. More than half of them, 51%, have remained in Texas for residency, and 17% have stayed right here in Austin. And it's important to recognize that, on average, American Association of American Medical Colleges shows that about 54% of those trainees who complete their training with their residency in a state will go on and practice there in Texas. But here in Texas, we find that that average rises to 66%. So our programs are actually retaining within Texas a larger percentage than the national average. On the next slide, I'm going to show you here, this is a video from one of our students. Go ahead.
My name is Woody Green. I'm an emergency medicine physician working here in the community. I work at all of the local Ascension sites, mostly at Seton, Maine, over near 38th and Lamar. I was born and raised here in Austin, born in a little house on West 11th Street back in 1979. Lived my whole life here. Went to undergrad at UT, graduated in 2002, and then worked as a paramedic for a decade after that before applying to medical school. Getting in here and then matching to residency here as well. So it's been this kind of dramatic, kind of arching journey, all in the same city. The part of the mission that really spoke to me was taking care of those that are most vulnerable in this community. I spent 9 years as a paramedic working for Austin Travis County EMS prior to applying to and starting medical school. And EMS and ER is where I work now, function as kind of the de facto safety net for a lot of people who either are uninsured or don't know how to navigate the healthcare system as it is. And so a lot of the people that I met, talked to, made friends with, and took care of kind of fell into this category. And I was hopeful that DelMed, in its ambition to kind of rethink how we take care of everybody, but including this specific population, really spoke to me. My third year was a distinction in design, and we had a capstone project during the spring semester. I worked on a 3-person team, and we partnered with Austin Travis County EMS. We ended up designing a pilot program targeted towards a program put out by the Center for Medicare and Medicaid Services. The program was called ET3, and it basically expanded the reimbursement opportunities for EMS. The standard was only reimbursement for transport occurring to an emergency room. And this expanded it to opportunities to gather reimbursement for treatment in place or transport to non-emergency room destinations. We helped them design that pilot so that they could be a part of that program, and they did. They're doing it currently. Working in EMS and now in the emergency room, the vast majority of my patients, especially when I'm working at the Safety Net Hospital at Del Seton, are taken care of by our central health safety net system. They have MAP cards and they go to our community health clinics. But we also see lots of patients who are not covered by any of these systems. And there's a pretty dramatic difference between the two as far as how you take care of them. Discharging someone back to the street who has no resources, no way to follow up, no kind of knowledge of how to follow up, can be very dangerous, and often we end up just admitting these people to the hospital for social reasons to kind of help take care of these issues that could be managed outpatient if they had more resources. A lot of times people covered by MAP cards are able to follow up outpatient and get these things taken care of, which makes us feel a lot better as their physician in the ER.
So in graduate medical education programs like the one Dr. Green completed in emergency medicine, these are expanding here at DelMed. As you've heard, we've more than tripled the number of residency and fellowship programs from 15 to 48 since 2015. And the number of residents has increased during that same time period by 70%. Of DelMed's 449 residency and fellowship graduates who have immediately entered practice, since 2015, nearly half have stayed in Central Texas. More than 2/3, or 69%, stayed in the state, well above the national average of 54%. Mike?
So what's ahead here with respect to education and training? We'll continue to focus on expanding our graduate medical education programs, which will bring more doctors, many specializing areas in need to Central Texas, and on focusing on training on important physician competencies like quality improvement and eliminating health disparities like you heard. I should note that all residents at DelMed complete a Foundations of Care transformation training, which emphasize value-based care, quality improvement, and eliminating health disparities like Woody discussed. This foundational training, which is also available for our fellows at their option, ensures our physicians advance their skills as system-ready leaders and are prepared to engage the critical work of transforming health and healthcare for our safety net population. And we'll measure areas of specialization, demographics by specialty, retention to Texas, and safety net care involvement along the way.
So the third area of permitted investment and a third focus of academic medicine is advancing research and discovery. So here to talk about this, I'll invite Dr. Tim Mercer, a faculty member in our Department of Internal Medicine and Population Health and Chief of the Division of Global Health within Population Health. Tim?
Thank you. Good evening, everyone. Tim Mercer, Associate Professor at Dell Medical School and a practicing primary care physician with Community Care's Healthcare for the Homeless program, and I'm the director of the M3 team, which stands for the Mobile Medical and Mental Health Care team. And so to sort of describe the genesis of this care model, I want to tell you a story about that gentleman in the picture there who was my patient. And He lived under the I-35 overpass for many years, and when he could make it into my clinic, I felt capable of caring for his heart disease and other medical comorbidities, but less capable caring for his schizoaffective disorder and his severe methamphetamine use disorder, and often unable to meet his unmet health-related social needs, namely housing. He was connected with other partners and care providers in our community, but ultimately struggled to connect that all together and get the care he needed due to the siloed, fragmented nature of the care systems, and the burden was often placed on him, and he ended up night after night back under those streets. And some days he couldn't make it into my clinic at all. He actually had very poor vision and struggled to navigate the bus system, or because of his competing mental illness or addiction or daily survival needs, just couldn't make it into clinic. And so for many years, he suffered under the street, and it was, that's not a very unique story in our patient population, and it was that that really led to the genesis of this new model of care that we call the M3 team. Next slide, please. And so the M3 team is a novel, mobile, patient-centered, integrated care model, initially funded by SAMHSA, the Substance Abuse and Mental Health Service Administration, a federal agency that's part of HHS, that brought together an important collaboration between Dell Medical School, community care, and integral care to provide a holistic, multidisciplinary care model for people experiencing chronic unsheltered homelessness, a chronic medical condition, a serious mental illness, and a substance use disorder. So arguably some of the most vulnerable and complex members of our community. And we put, in this model, we put the patient at the center and wrapped a care team around them, bringing the expertise and the resources of each of the partners together to address their medical needs, their mental health, their addiction, and their social needs. And importantly, we developed and implemented this model, and importantly are rigorously evaluating its outcomes so we can change and adapt along the way and show its success. And so we're, back one slide. So over the last few years, we've had nearly 300 patients referred, to the M3 team. We've enrolled about 80. It's an intensive care delivery model. Of those eligible for MAP who are enrolled on the M3 team, all of them have MAP, of those who are eligible. And then about 40% of patients we've helped facilitate get access to Social Security, disability benefits, and Texas Medicaid. We work to ensure enrollment in other social safety net programs such as SNAP or transportation assistance. We are measuring improvements in mental health and have seen of those enrolled on M3 a significant reduction in depression and other mental health symptoms, and improvements in functioning and reductions in substance use and alcohol use after the first 6 months. We've shown increased access to primary care services, and importantly, a concomitant, a nearly 50% reduction in emergency department visits of those enrolled on M3 compared to the 6 and 12 months prior to M3 enrollment. And then importantly, we've helped navigate close to 70% of our patients into housing. And so just in conclusion, I think this is a novel care model that only happens because of the collaborative nature of our partnerships to transform health delivery for our safety net population. And we hope this work will be generative, leveraging the initial investment to attract increased funding and investment from our health system partners to scale and expand this model. So thank you very much for your time.
Thank you, Tim. So all this work is important, but in particular, I want to highlight how he contributes to our research mission, including Dr. Mercer. Delmed is home to 97 researchers pursuing over 224 active research projects. Our research footprint is rapidly growing. In the period from 2018 to 2022, only 3 medical schools had a greater increase in the Blue Ridge rankings. This is a ranking that measures National Institute of Health funding as a measure of research activity. Combined with UT's aspiration to be the world's highest impact public research university, we really do expect that this momentum will only continue to accelerate. Next slide. Here are just a few important research examples that are underway that are focused on improving the health of people who may be part of the safety net population. We've just listed some of them here. These projects are led by investigators recruited from world-class medical institutions, including Harvard, Johns Hopkins, Washington University, and St. Louis, and more. Some of these projects, we just want to share a few examples, include stress reduction for low-income people with COPD, understanding barriers and access to organ transplantation in Central Texas, the value of prophylactic medications for HIV prevention in Central Texas, suicide prevention for young adults in Texas, the impact of telehealth visits and avoiding urgent care for pregnancy among the underserved, culturally tailored preventative care for individuals with risk factors for kidney disease, and a culturally tailored scalable asthma intervention for high-risk children.
So what's next with respect to research and discovery? We're going to plan to continue our research infrastructure with a focus on community-based participatory research, and we'll apply the principles of this type of research to measure the impact, particularly of the underserved and MAP population. In addition, this work is ongoing to establish research programs at Central Health through collaboration with Del Med and the University of Texas at Austin. A couple of examples of these is assisting Central Health with setting up an appropriate research infrastructure to align with the work that the M3 program that Tim discussed, as well as offering institutional review board participation to Central Health faculty. We'll continue to measure outcomes and quality that relates to this participatory research as well.
So it's a complex slide. Why did I put it in there? It's very difficult to really know how to measure community engagement. So when we talk about community engaged participatory research, many struggle to how do you actually measure this? And a group, the National Academy of Medicine had convened, was a group that was really focused on developing measures of meaningful community engagement. And it really requires working collaboratively with and through those who share similar situations, concerns, or challenges. This complex slide, however, did highlight 4 points I wanted to make. At the center of research that's really community-based really sits upon this foundational element that it is co-created. It's built on a foundation of trust, it's bidirectional, it's collaborative, it's culturally centered, and that it's really important to underscore how this is the catalyst. But these principles are really needed to focus in key domains of this engagement around strategic partnerships and alliances, expanding knowledge, improving health and healthcare problems and programs and policies, and to really strive toward thriving communities. And really, I lay this here because as we look forward and think about how are we measuring our impact in our community, I felt that some of these principles could be adopted and implemented in some of the work we're doing. Which leads us to the next slide, please. So with respect to community collaboration, collaboration is core to Del Med's work to advance a system of seamless, high-quality care to address cares and gaps in specialty care where we can be strong partners. We highly value broad community collaborations focused on areas ranging from mental health to substance abuse to non-medical drivers of health, impacting a range of populations, including MAP patients. And I often talk about the importance of research being done with the community, not explicitly on or for, but specifically with, as true partners to identify those needs that they identify. Next slide. Nick.
So just wrapping up, where do we see the future of our partnership going? Well, number one, I think it's very bright. We want to broadly overview the future of our partnership as we see it, supplementing the information we've already shared about our work together on direct patient care, education, and research. Ahead for us together are a few things. Number one, an alignment and collaboration around identified strategic priorities. In fact, we've already outlined some strategy sessions that we'll be embarking on in the next month in partnership with Central Health. We'll address prioritized community health needs, including mental health, diabetes management, and cancer prevention. We'll continue the successful clinical programs that have been outlined here tonight, provide additional specialized care more efficiently by developing contracting, such as the Master Services Agreement for Specialty Care we talked about, and professional services agreements where we are involving co-recruitment with Central Health. We'll provide medical education to provide care in the hospital and community-based settings that will encourage our providers to stay in the community and serve the safety net population. And lastly, we'll continue to work with service-based research related to quality improvement projects in the safety net community-based settings to improve care for the Central Health population. Yeah. Together, we're working to really provide that comprehensive ecosystem of care that involves elements such as designing the appropriate systems of care, scalability, capacity building along the way, and in the environments of care that we talked about tonight, from the street to outpatient clinics to inpatient care and home care. You're all critical as partners with this, and we hope to continue to do this. Claudia.
So to close, the last slide, we covered a lot today, but I just want to underscore and go back to the beginning, which is really what attracted me to Austin, and really that the role DelMed's mission and vision is to focus on improving the health and healthcare for all, especially the most vulnerable, along with our unique and unprecedented relationships that the medical school has to this community and with the university. I can honestly say that today I'm even more excited than I was 7 months ago. It's a lot to do and a lot to do together. And in the next 5 to 10 years, we're going to continue to see the growth and the benefits become even more exponential. We've had this theme of generative as we focus on both the safety net population and overall expanding our footprint of care for all of our community. There's so much opportunity ahead to advance health access, quality, and outcomes, to address health disparities, and particularly for those most in need in our Central Texas communities. And I just can't emphasize enough the honor and privilege it is to be able to work with all of you, to collaborate with all of you as we continue to build upon this partnership for the benefit of our communities that we all serve. So thank you for your attention.
Thank you so much. Dean Dr. Moore, Dr. Mercer, Dr. Edmond, thank you very much for your time. It's almost like watching a child grow because we have sort of seen this school from when it was a thought, all right? And now we're looking at all of the wonderful activities that
Can you please speak up?
Sorry. All of the wonderful things that you guys are doing, not only for the region, but for our population and the population that we serve. And so we appreciate your time. We appreciate the fact that you're always available when we need questions answered, or we're trying to figure things out, or coming up with new ideas. It's great to have partners that we can utilize to not only provide a great service, but also to provide us feedback and brainstorming on how we can do better things for the population that we serve. So thank you very much. I appreciate all of you for taking the time to be here. And I am now going to open it up for questions, and I'm going to start with Manager Montwani. I like to switch them up because they never know where I'm going to start.
Thank you all so much for being here. This, to echo in some ways what Dr. Bell shared, the sophistication of the presentations that we've received has grown both incrementally and in some ways perhaps exponentially, approaching and arriving at this presentation. This is the first time, I think, that I've seen a presentation that not only assuages some concerns about the best ROI when it comes to different approaches to serving the population that we all steward, and not only assuages many of the concerns about maximizing the best ROI there, but it also gives me a lot of hope. And not only hearing the firsthand accounts from, of course, Dr. Inman, Dr. Mercer, and anytime you have Donna Shaner involved, it's going to be really compelling. But to hear the language of co-creation and discussion of how we will continue to really iterate our shared interpretation of our agreement together, and I have a lot of hope now. At the end of the day, I think it's also important that, and you'll see that from me and certainly others on this board, that we continue to hold all parties accountable, especially when we discuss the potential for brighter outcomes of our MAP patients and all of the indigent population who are under the poverty level or not having or having challenges in access to care. And so when we do say that we are going to take a more sophisticated and comprehensive approach to tracking the outcomes of the patient continuum and their journeys who are MAP patients, that perks up our ears. And, there are 50 different indicators that might come to mind immediately. And I'll spare you all them, here, obviously, but those are definitely the kinds of things that I would like to continue seeing. And again, more than really anything, I appreciate y'all's time here. And just the effort that was put into this presentation. Whereas before, I might have been sifting through spreadsheets myself to get a sense of, sort of physician recruitment and retention here locally. We're getting visualizations, and we're getting sort of synopses, and we're getting historical looks. We're getting, comparisons to other baseline trends, and that really helps contextualize this. I'll wrap this up by saying I will still feel a lot better when I know that we have a party who is not one of us, perhaps an economist, a healthcare economist, really do a more rigorous ROI study to see how we can continuously improve and look at both double bottom line, of course, of the financial investment, but most importantly, patient outcomes and the ROI there. So thank you all so much, and forgive my verbosity if that's a word.
Thank you very much, Manager Motwani. Manager Martin.
You're bouncing. First off, thank you all so much. And I really want to emphasize, thank you so much, your example, yours of sort of the passion that I emphasize to my medical students and residents, that it's an intangible. And I really hope that you all do stay on that mission to emphasize that to the students, because so much of what we do, we take for granted. It's like, you got someone glasses, well, big deal, right? Well, you change the person's life. And I think if the medical school stays on that focus, I think that'd just be wonderful, and it's been great to be a partner to that process. So thank you very much.
Can I say one thing? That is, so we have 2 residency classes, and we highlight that this is part of our mission, and it's one of the top reasons we're attracting top residents is just this focus, just this priority.
Well, thank you.
Thank you, Manager Martin. Manager Jones, and don't forget to turn your mic on.
Okay, thanks very much. I certainly appreciate the presentation and very supportive of the work that is being done in our community. But as board members of the hospital district here, just want to emphasize our responsibility with the dollars that we have as taxpayers. And so the $35 million that we contribute may be a drop in the bucket to your overall portfolio. I was wondering, can you share with us what your annual operating budget is? Just for information purposes, I don't know if you have that available to share with us now, or what percentage our contribution is of that.
You want to take that question?
Well, that would be, a lot of the financial reporting processes would be handled in the JAC, actually. That's probably the best forum to discuss the finances of that within the confines of the affiliation agreement. So unfortunately, we can't really share that here tonight.
As far as, I would just follow up though, I know that in the closed session, there'll be further discussion around financials. I don't know if you want to comment on that, Charles?
Right, Dean. Manager Jones, we need to finish up a discussion that we had with regard to the finances and UT. So that may further enlighten you a little bit later on in the meeting.
It's just in the closed session.
Where I was heading with this was basically is that as fiduciaries for the dollars we oversee, we want to make sure that they are addressing those. And so I want to emphasize that as a start-off point. I admire what Dell Medical School is doing. I think and from the information you shared tonight was very enlightening and very helpful to understand that. I do want to talk a little bit about one of the maps you did show, this one here, where your students, residents, and fellow practice, I guess, are providing services. When looking at this, first of all, these are Travis County's taxpayer dollars, so our contribution is basically Travis County. And when we look on this map, if you look at the area of northeast Travis County, if I'm reading this correct, there are no resident students or fellow practice in that area. And I guess I say that as one of the reasons we're interested in trying to work with Dell Medical School is to encourage, train, and recruit ultimately providers to this area. As a public health professional, one of the things we see in the data is that in that same area of the county have the highest rates of mortality and morbidity. And one of the contributing factors is the lack of access to health care. Now, Central Health, as a provider of care, through our providers, serve that area. Certainly, our expectation is that we would try and recruit, train, and incorporate providers in those areas. So I would encourage you as you look at your students and recruit students, and to go to the schools in this area to talk specifically about how do we get more individuals, particularly individuals of color that come from that area, because that area is largely of color. And I would encourage you to look at how do we work together to do that, so that we don't find ourselves providing good service to the parts of Travis County, but not to those where the indigent and those who are in greatest need are.
Thank you. A really important point I would just want to emphasize, that's where the students are. It's not necessarily where care collectively is being given. So I think that, but your point is an important one. And I think going forward, we'll continue to build out those maps, work together as we build out services moving forward to address those gaps, not just in the continuum of care for a patient, but in where our MAP patients are living and where they're located, to be able to really be the fiduciary responsibility that you've outlined. So completely understand your point.
So are you providing services in those areas you're saying?
So I would actually have to say, being relatively new, I don't want to, so what I will do is we will look at that and review it so that we can have a good understanding of that to provide that information.
Okay, then. I think that would basically, thanks very much for the presentation and welcome. You've been you said
7 weeks, 7 months.
And
7 and 7.
7 and 7.
Welcome
Lucky
to
7.
area.
We did.
Manager Kitchen?
I want to add my thanks to what my colleagues have said. I think that you all represent a very exciting opportunity for this community. And I've had the opportunity when I was on the city council to work with Dell on some analysis related to COVID. So I wanted to thank you all for that. So I see you all as a resource and a thought leader and someone who can really be a key partner in the community. I also share what my colleagues have said, that we have a role which has to do with accountability, and I think that's accountability as a partner. Your role and our role to be accountable for the use of these dollars and to show outcomes. So all of our questions and comments go to that end. So with that said, I have a request and then a question. My request is I'd like to understand more about the M3 program. I'm somewhat familiar with that program, but I'd like to understand more about it, and this is for after today, in the context of that kind of partnership I just talked about. So what happens next with this program? How is this program taken to scale? What do you all see? I mean, you're learning about outcomes from this program, but what do you all see as recommendations for taking a program like this to scale, for the future of a program like this? How do you cover the full continuum of care so that you're not begging for housing, for example, or other aspects that need to be part of a program like this to truly serve these folks? So anyway, I'd like to understand, and that's a longer conversation for later, but I'm excited that you all are involved with that program. I see you having the capability and the resources and just the gravitas to bring resources to the table, as well as thinking and analysis and all that. So I just have a request on the M3 program, and I'd like to talk to you more about that. And then my final question is I'm just really curious. I mean, I really appreciate hearing the emphasis on serving our patients in this community. So I'm wondering what you think and what you all think is the major or key issues for our community with regard to serving this population. What's our big challenges?
it'd be, if I could, Chris, if I could take that down to one thing, that would be challenging to just come a single thing.
Yeah.
I think we highlighted the access is,
Okay.
I would consider access to be probably one of the top issues.
Okay.
And then not only coming in the door, but as you heard from Dr. Mercer, how can you continue to wrap services around a patient through that process? So access is everything about navigation and knowing where to go and who to go, but then also not suddenly losing that person through the challenges of life that disrupt their care and disrupt their outcomes. And so thinking creatively and collaboratively about how to tackle that is part of the follow-up meetings that we're actually doing here for the month of August. I know Monica's in the office, is there somewhere. And maybe, Mike, you want to follow up on that?
Yeah, it's just that what happens with patients after they're served and where do they go and how do we help to fill in those gaps is really, I think, part of the challenge that we all face, right, moving forward. And, you know, you highlighted some of the aspects too, you know, with the M3 program and the lack of housing is a clear gap, and how do we help? What's our role in helping, you know, close that gap? So I think that's the biggest challenge with this particular population.
And identifying the problem is one thing. You spoke also about the importance of having metrics. Are you moving the dial? Do you actually have any way to know? Are we just feeling better about having tried?
Right.
Well, that's not going to be enough. We're going to have to move the dial. We need to together to find ways to measure that. And the analytics that requires is tricky in an environment that doesn't have a very robust data infrastructure. But the use and ability to connect with our patients and develop those analytics and work together in deciding what the key outcomes are is going to be important. It can't be all of them, but there can be several key ones that we can measure. And to this point about stewardship and accountability, that has to be foundational to our approach. So we are stewarding these resources. We are also accountable, and then being able to pivot and redirect if something's not working, because many things get stood up. We celebrate them. We can write a paper about them, write grants, but what you're already hearing here is the scaling from Dr. Mercer. The next large grant is based upon the work that's been done here. You begin to scale. And then we have a very entrepreneurial medical school that thinks, now how do you take this issue around bringing services around the homeless and bring that to scale? In fact, there are discussions right now with our faculty, Minnie Callan and others, around her factor health efforts in homelessness, and she wants to scale something now to the 5,000 and beyond, which doesn't sound huge, but it begins. And where does a medical school help enable that? Where does that go into another environment to be able to really allow to scale? So recognizing our limitations, but also our assets to be able to scale is important, because validation is research, scale is impact.
Thank you.
Thank you, Manager Kitchen. Manager Zamora.
Dean, welcome.
Thank you.
On behalf of the Travis County Medical Society, as the past president and a leader at TMA, TMA and Travis County welcome you to Texas, to God's country.
Thank you.
We can't thank you enough. Mike, love the colors.
Okay.
You know, when Senator Watson, who's now our mayor, and I met in 2010 about the 10 for 10 that he thought of, because we were the only state capital without a medical school. It was his dream that we created this. You know, it was his nickel proposal in Prop 12 that allowed us to bring the school here. And our taxpayers have always been generous. And they gave us that nickel, and we went in town from town hall meeting to town hall meeting, telling our constituents that this was going to be used for services. And that's what y'all are doing. Y'all are expanding services by bringing all these extra specialties we have now. You know, when I sat down with Senator Watson in 2010, I said, Senator Watson, it's not going to be difficult to recruit the best of the best, and we have. You know, Chair Edmonds, Dr. Mercer, Michael, yourself. You know, we have an incredible school here. We have incredible students. Like you said, they're very unique. Each child is unique. Joe and I have the privilege of teaching those students through the Department of Population Health. We love our students. They're incredible. They always bring a challenge every week that they come to our office. So I want to thank you for coming. It's you know, welcome to Texas. Hopefully you will get to meet our mayor, Mayor Watson. Okay, good. He's an incredible man. He was our leader. He started this. It was his dream to bring this school here. and he's doing a great job. And we, like Dr. Bell said too, you know, we watched you guys grow, you know, from, you know, Dean Johnston to now this whole collaboration of physicians that you have, and nurses. Thank you.
Thank you. Thank you very much.
Thank you, Manager Tamora. Manager Musai?
Thank you, and welcome.
Thank you.
I echo everything that has been said before me, and one thing that stood out to me is the compassion and empathy that everyone from your faculty have really stated. And when you said, Dr. Edmond, socially conscious, that really brought to light to me, like, because of our special population, really addressing the barriers outside of the clinical walls and having that individual who can listen to the patient's need beyond just addressing their immediate medical issue. We will not be able to improve their health outcomes if we did not address the barriers outside of the clinical walls. So I thank you for that. I love the story and the stats, and I just don't want to go over that one gap, and I think that has been identified within our community, and there's a tremendous need, and I did not see that anywhere highlighted, and I just want to get your thought. I know you mentioned access, but cancer care, that is a critical need, and many of our patients may not have access to your cancer clinic, and that is a desperate need, especially for our population. So I would love to hear your insight, input, what your vision is, and how can we fill in that void and gap for our population, because as of today, I don't think anyone knows how cancer care, the continuum of cancer care is delivered for our population. And that is a issue that we all have the ownership and need to address immediately. So that is something that I hope that we can work on, and I would love to hear your insight on that. And one final note on that, your innovation education training for students, especially high school students, has been phenomenal. I know multiple students who love your programs and who are really anxiously planning on pursuing a health profession. So thank you on that.
Thank you. When I talked to the graduating residents when I was a chair and now as a dean, I emphasized one of the first points you made, and that is that patients want to know you care before they care what you know. And it's not my quote, it's a well-known quote, but it resonates quite a bit with me. And I can say I was very inspired by the faculty I had an opportunity and privilege to meet going through the process through my own recruitment here. And seeing how it's also palpable and resonates with all of you makes me proud of them, and knows that we're on the right track, because that is at the center of what we do. With respect to cancer, absolutely, that will be an area of ongoing discussion and focus. The unique challenges for cancer care among our safety net population and our MAP patients, I don't have the answer today, but I can just tell you that there have been ongoing discussions about what does that program look like, how can we build around that together, and really bring our shared expertise to that, the perspectives we might bring to the delivery of that care, the partnership, and then working with the barriers through that process. There are a number of grants and CPRIT proposals that are looking at enhancing screening of the population, all the way from screening to care. But again, those are research efforts upon which to maybe inform elements, but they're not addressing the full continuum. Right. And I think importantly, what I don't want to see happen when I talk about working with, not on, is that we are very careful not to, in an exploitative way, not intentionally, but begin to do research on these topics, but not really hold ourselves accountable for actually addressing what we're learning. So I don't ever uncouple the research investigation from the next step of understanding how that's going to be, what clinic we need to build around it. I don't think we're there today, and I'm learning the whole cancer environment is, I would say, evolving. But this will be a component for us to be, I think, working together on. And I don't know, Mike, you want to add anything to
No,
that?
I think it's spot on. Thanks.
So,
Thank you.
go ahead.
It's evolving.
No, thank you. Just really quick, just follow up on that. It's not enough just to start a program.
Oh, yeah.
Like,
No.
you screen them.
Oh, yeah.
And then what happens? They
Agreed.
fall off. Like,
Right.
who's going to diagnose them and where do they seek treatments? And as I mentioned, continuum of care.
Right.
So,
Yeah, and
Spot
that,
on.
that was my point really, that it's absolutely not enough. And in fact, sometimes it's the wrong thing if you're screening, but you don't have all that to follow behind it. That's actually not success. So I'm completely with you, appreciate that you raised it and committed, and I hope next year we can come forward with something more established that we can share and celebrate at that time in terms of the progress we're making.
thank you so much. Appreciate it all.
Thank you, Manager Musaitu. Manager Valadez.
Thank you. And welcome, thank you for being here, and welcome, bienvenidos to Austin, Texas.
Thank you.
It used to be one of the most segregated cities in the United States. It's probably still high up there. And to that, I'm going to say this. I want to thank you for the work that you're doing. You are not the ones that initially created the programming, but I do want you to know that we appreciate everything that you're doing to help close the disparities gaps that have existed historically in this community. In 2010 and 2011, it was because the Latino Healthcare Forum was pushing for, when we knew UT was coming, let's develop with AISD pathway to a grow your own pathway to medical school. And not only with medical school, let's do what they've done in El Paso. They grew their own teachers from elementary school to the high school, graduated them and sent them to UT Medical School and UT Education Schools and all the other programs in El Paso. We wanted that to happen with the University of Texas here. That never quite happened. They've tried to implement a program, but they haven't really been successful. I hope that UT will pursue that agreement, collaboration with the school districts. There's 17 here in Travis County, and helping to develop a grow your own, not only for your medical school, your pharmacy school, your nursing school, your education programs, but everything else. Also helping with the school districts to develop a literacy program, especially a medical literacy program, because we have so many families that are blended. The majority of our population in math is non-English speaking. And so what happens when the parent needs to go to the doctor, they pull their child out of school and they go and serve as interpreter for their parents or family members. So those are some of the issues that address in accessibility, in the implementation of a plan that's patient-centered, in development of wraparound services, development of tying them to social services. It's the language barrier, which I believe is actually almost as telling as the economic barrier, and the refusal to provide equal educational opportunities to all children, not only in Texas, but here in Travis County also. So anything that University of Texas, which gets the bulk of our HUF fund money, can do to equalize opportunities for the Texas children, for the children in Texas, will be greatly rewardable and appreciated by us all. Another bottom line thing is that we know that we approved the $35 million for y'all to receive. And to follow up a little bit and just to emphasize that, one of the comments that Manager Jones made is that we would like to see, at least me, this Central Health Board member, would like to see the University of Texas Medical School spend its $35 million on our population, on our safety net population. You all have a much greater budget, and I understand that, and would welcome you all getting much more money so that you can do more. But when we hear that $35 million, some of it is returned to the corporate office, is very disheartening. So I want to make sure that you all understand that it is not a criticism as such, but rather a concern that help advocate for the poverty population, the safety net population here in Travis County, want the University of Texas to be our partners, but we want them to understand the need for them to spend that money on our population, not on anything else, on our population. So please commit that to heart and put it at the top of every door so we can hopefully make changes by closing those disparities gaps that will continue to exist so long as we're dealing with institutionally racist systems. And we all know and understand that is a fact. It's not a hypothesis. It's not anything else. It's a fact. I do want to say that congratulations are in order for what you are doing and the number of clinic doctors that are working in our clinics, especially community care and integral care, because we do have great needs in our communities of poverty, and also our communities that don't speak the English language. My daughter, who you may have seen in the picture with me here, graduated from Rosedale High School, which serves the medically needy and chronically ill, medically fragile and chronically ill student population. It's the only one that goes from 3 to graduation from high school, and they'll serve you until you're 22. But there never has appeared to be a really good transition from education in the special needs schools or for our special needs population, which end up being the majority of the times the adults on the street that are being served by the street teams or the M3 program or whatever. If we can get them down at the 0 to 3 level, early childhood level, and continue to work with them, because that continuum of care is what we are talking about, not once you're an adult and beginning to get care. No, from 0 to 3 and up. And developing curriculums that make sure and prioritize that to your doctors, to your students, and to your staff in all the various professional colleges that you have within the University of Texas system is imperative if we truly want to get ahead of what is happening not only in this state but elsewhere. So if you can see what's happening at the border, if you can understand the pain that people living in poverty feel when they don't even have the money to go to the doctor, oftentimes don't have anybody that can help translate, and many times those doctors that they go to may not have anybody that can interpret for them. That's one of the reasons it's so critical that your staff needs to be representative of those populations and what they speak. And they need to have learned experiences. They need to come with a perspective and a lens that shows that they understand completely where these people are coming from and what they need in order to have a better quality of life and to even have a life at all. And so I thank you for your commitment. I thank you for coming to Austin and hoping that you can make a dent by righting the ship a little bit. And I look forward to working with you in the future. And I look forward to you all improving upon what foundational achievements you have made already.
Thank you very much, Manager Valdez.
Thank you.
We appreciate that.
I do appreciate that very much.
Thank you. Last but not least, Manager Brinson.
Hi. So I'm sure you can tell that each of us are very passionate about what we do, and we all have our own ideas. And we all have our own ideas of what you all should be doing. I mean, of course, we always do. Everybody has an opinion of what they want you to do. But just in that line, we are interested in everything, and and what you presented today was interesting in their choices, but I think we wouldn't mind more. We're extremely interested in equity in our community, so we would want more detail on your staff, perhaps, just some idea of what your population is as far as the people who work for you, as far as the residents, the students you're taking in. And then also, what are you putting out? So I'm glad to see that a lot of the people stay in Austin or in Texas, but what are they doing? Like, what kind of physicians are you putting out? And what kind of specialties are you focusing on? And how is that going to serve what we're uncertain what the future's going to hold? But, I think that would all be very helpful. And as Central Health tries to take more control of the MAP patients and the patients in general in Austin, I do think that there could be some very interesting collaboration that could occur. But it can't occur if we're not talking and hearing, because, it gives us good ideas.
Yeah. So completely agree, and it's actually aligning now. So we're entering into our strategic planning in the fall. We specifically planned a series of meetings through August here with Central Health to take a deeper dive into the health equity plan that Central Health has put forward, understanding the prioritized areas there, and then with that in mind, as we're leading into our strategic planning for the medical school and broadly for our health enterprise, number one. Number two, a lot of the data we actually do have on our website articulated in terms of the distribution in our classes and our residencies. But your point's a good one, which is once our residents graduate, what are they doing, and in what areas of the population are they working? We know what our faculty are doing. We know that 81% of our faculty are providing care to the safety net population as part of either full or part-time. But getting those analytics is part of what we refer to. Just to kind of put it in, as a medical school, we've graduated 4 medical school classes. The average residency lasts from 3 to 7 years. So we don't yet know where they've landed. So we're kind of watching to see, and we know what they're talking about when they come in. We know why they were, as we heard from Dr. Edmond, what drew them here. And now we're sort of wanting to see, what do they grow up to be, and so we're also interested and believe that, frankly, regardless I don't mean to diminish it, but coming with a lens toward understanding the impact of disparities across healthcare, health and healthcare equity is something that we continue to nurture, grow, talk about, and better understand about how to equip our students for this environment to be able to have the most impact. And so from that standpoint, I think it's absolutely critical to do this work together, to appropriately align in the components of our missions. We have a broader mission that's a part of our mission, but health equity crosses everything. It crosses research, education, practice, everything. And so with that in mind, we are definitely committed to that collaborative approach that couples accountability and stewardship to deliver impact. And with that, do you have anything you want to add to that, Mike?
The only thing I'll add is we're continuing to develop those analytics around what's happening to our residents. And I think also then fellows as well. And Claudia can speak to this better, but oftentimes where you land in fellowship is where you end up practicing. And that we'll have a lens to that as well moving forward, if that helps.
But thank you.
We want to know.
Yep.
As I said, so.
Thank you.
Thank you, Manager Brinson. And finally, thank you again for your time, for being here, and for the great information you provided us.
Thank you. Thank you for the opportunity and the honor. Thank you.
All right, members. The last 3 agenda items are going to be in closed session. So I am going to bring us into close. And I announce that the board is convening in closed session to discuss agenda items 2, 3, and 4 under Texas Government Code 551.071, consultation with attorney, and agenda item 5 under Texas Government Code section 551.071, consultation with attorney, and the Texas Government Code section 551.085, governing board of certain providers of healthcare services. It is Wednesday, July the 26th, and 7:15 p.m. Oh, and the items that will be discussed. Agenda item number 2, receive and discuss updates on the 1115 Medicaid waiver and the Community Care Collaborative and other healthcare delivery partners, programs, projects, reporting, and arrangements, including agreements with Ascension, Texas and the University of Texas at Austin. Agenda item number 3, receive and discuss a briefing regarding Travis County Healthcare District doing business as Central Health versus Ascension, FKA, Seton Healthcare Family, cause number D1-GN-230000398. Agenda item number 4, receive and discuss a briefing regarding Birch et al. Versus Travis County Healthcare District doing business as Central Health, and Mike Giesland, cause number D-1-GN-17-005-824 in the 345th District Court of Travis County. And agenda item number 5, receive and discuss an update on Sendero Health Plans, financials, and proposed business strategies. All right. That was long enough. Everybody should have left by the time it was reading.
We're here to support.
We'll wait for a couple. Ready? Thanks. We are back in open session. It is Wednesday, July the 26th, 2023, and it is 8:20. And we covered agenda items 2 through 5. There are no motions necessary on any of those items. Agenda item 6, confirm the next regular board meeting date, time, and location. Managers, our next Central Health Board of Managers meeting is tentatively scheduled for Wednesday, August the 2nd, 2023 at 4 p.m. at Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. At this time, I'm ready to accept a motion from Dr. Martin to adjourn, and Manager Kitchen seconds. Any further discussion? Hearing none, all in favor?
Aye.
Any opposed? Motion carries.
Thank you, members.
Thank you very much, members. I